Genesis congenital torch infections human immunodeficiency virus neonatal conjunctivitis fever in infants. At Goa Home Library lists co-settings. Prenatal asphyxia and hypoxic ischemic encephalopathy. Perinatal asphyxia, a common cause of death in neonates, is caused by compromised placental or pulmonary gas exchange and can occur during the antepartum, intrapartum, or perinatal period. Persisting impairment of blood gas exchange results in oxygen deficiency, hypercapnia, and blood acidosis with potential subsequent compromise of cell function in various tissues, example heart, muscle, brain. The brain is the most vulnerable organ in the context of perinatal asphyxia, and the development of hypoxic ischemic encephalopathy is a potential consequence. After rapid evaluation, eligible patients require therapeutic hypothermia over a period of 72 hours to minimize brain damage. Depressed myocardial function can exacerbate ischemia and cause subsequent short-term complications with end organ damage in other tissues, example kidneys, lung, liver, gastrointestinal tract, bone marrow. Long-term complications of perinatal asphyxia include irreversible neurological damage, cerebral palsy, and periventricular leukomalacia. W.A. Osus. Definition. Sent perinatal asphyxia is a condition characterized by fetal oxygen deprivation that occurs in close temporal proximity to birth. It may lead to impaired cell function in various tissues and result in end organ damage, example encephalopathy, renal injury. Sent neonatal encephalopathy, a syndrome of CNS dysfunction in the early newborn period characterized by an altered level of consciousness/seizures, difficulty initiating/maintaining respiration, poor tone, and/or depressed reflexes. Copyright several conditions can be the cause, example hypoxic ischemic encephalopathy, inborn errors of metabolism. Hypoxic ischemic encephalopathy, HI, is a diffuse disruption of brain function and/or structure caused by inadequate tissue oxygenation, example due to cardiac arrest, trauma, drug overdose, perinatal asphyxia. It is the most common subtype of neonatal encephalopathy. W.A. CE. Epidemiology. Sent perinatal asphyxia accounts for 900,000 fetal deaths per year, worldwide, and is one of the main causes of early neonatal mortality. Hypoxic ischemic encephalopathy occurs in 1.5:1,000 live births in the US. 21. Epidemiological data refers to the US, unless otherwise specified. W.A. CE. Etiology. Sent perinatal risk factors. Copyright fetal cardiovascular abnormalities, example congenital heart defects. Copyright fetal pulmonary abnormalities, example decreased surfactant related to prematurity, aspiration of amniotic fluid, meconium aspiration syndrome, persistent pulmonary hypertension of the newborn. Antepartum risk factors play the biggest role. Copyright placental abnormalities, example fetal vascular malperfusion, thrombosis. Copyright congenital infections. Copyright substance use, example alcohol, cocaine. Amphetamines. Abnormal maternal oxygenation, example due to trauma, hypotension, severe anemia. Copyright maternal conditions, example diabetes mellitus, preeclampsia, congestive heart failure. Sent intrapartum risk factors. Copyright traumatic delivery, example shoulder dystocia, emergency cesarean delivery, failed vacuum-assisted delivery. Copyright cesarean delivery with general anesthesia. Copyright impaired placental perfusion, example placental abruption, abnormal uterine contractions, uterine rupture. Abnormal maternal oxygenation, example pulmonary edema in preeclampsia. Copyright maternal hemodynamic compromise, example amniotic fluid embolus, umbilical cord prolapse, nuptial cord, umbilical cord knot. W.A. CE. Pathophysiology. Scent pathophysiology of multi-organ damage SLL41. Hypoxia T sympathetic activity circulatory centralization to maintain perfusion of vital organs, example brain, adrenal glands, heart, reduced oxygen supply to peripheral organs tissue damage, e.g. kidneys, costal diaphragm, skeletal muscle, liver, 2. Prolonged hypoxia compromised myocardial cell function and ischemia myocardial contractility cardiac output worsening of ischemia in equals al. Collapse fine text outline. X perinatal asphyxia and hypoxic ischemic encephalopathy. Pathophysiology. Scent pathophysiology of multi-organ damage 3.4.1. Hypoxia T sympathetic activity circulatory centralization to maintain perfusion of vital organs, example brain, adrenal glands, heart, reduced oxygen supply to peripheral organs tissue damage, e.g. kidneys, costal diaphragm, skeletal muscle, liver, 2. Prolonged hypoxia compromised myocardial cell function and ischemia myocardial contractility cardiac output worsening of ischemia in peripheral organs scent pathophysiology of brain damage 5.1. Primary energy failure, antepartum/intrapartum placental dysfunction or postpartum pulmonary gas exchange impairment insufficient oxygen supply to organ tissue brain tissue acidosis, due to CNS susceptibility, osmotic dysregulation in cells cellular edema apoptosis 2. Latency period, lasting several hours reperfusion and recovery of some brain cells. 3. Secondary energy failure, 6 to 48 h after initial injury distribution of toxic neurotransmitters, oxidative stress, inflammation widening of affected area. 4. Brain injury, months to years after initial injury persistent inflammation, impaired neurogenesis, reduced axonal growth reduced neural plasticity, myelin deficits, brain cell death. WA. CE. Clinical features. Signs and symptoms of asphyxia. Scent short-term asphyxia O primary apnea, cyanosis, blue asphyxia, O heart rate O peripheral vasoconstriction maintains blood pressure and circulation scent prolonged asphyxia copyright secondary apnea, white asphyxia 1 O blood pressure, severely heart rate co muscle tone, J reflexes scent further course of perinatal asphyxia, varies greatly and depends on the duration of oxygen deficiency O may require immediate neonatal resuscitation copyright development of severe complications, example. Hypoxic ischemic encephalopathy, multi-organ failure, copyright full recovery is possible. Clinical features of hypoxic ischemic encephalopathy 6. Clinical stages of neonatal encephalopathy. 6. Mild moderate severe mental status scent hyperalert scent lethargic * comatose/stuporous. Muscle tone scent normal or slightly increased scent hypotonia * hypotonia, flaccidity. Respiration normal scent periodic apnea scent irregular breathing. Scent diminished deep tendon yen plus depressed deep tendon reflexes scent weak sucking reflexes. Absent neonatal reflexes weak/absent neonatal reflexes. May occur within 24 hours usually generalized seizures none after birth * increase after 24 to 48 hours of birth. Ocular motor disturbances, example nystagmus, bobbing, scent temporary behavioral abnormalities, poor feeding, irritability or excessive. Pupillary abnormalities, dilation, fixation or additional. Scent recovery after 1 to 2 weeks is. Tears crying/sleepiness possible unresponsiveness to light * self-limited, typically lasts. OS. OIEEE. Diagnostics. Neonatal assessment, 71. Scent general copyright should be performed within the first 6 hours of life, in all newborns showing clinical signs of neonatal encephalopathy, example difficulty initiating and/or equals AQO. Collapse fine text outline. SSSSEE diagnostics. Neonatal assessment 71. Scent general copyright should be performed within the first 6 hours of life, in all newborns showing clinical signs of neonatal encephalopathy, example difficulty initiating and/or maintaining breathing, seizures, abnormal level of consciousness. As neuroprotective treatment is time-sensitive, copyright allows estimation of the likelihood that perinatal asphyxia contributed to the development of neonatal encephalopathy. Neurological damage is the major concern after a hypoxic ischemic event. Scent neonatal signs. A hypoxic ischemic etiology of neonatal encephalopathy is most likely if one or more of these signs are present. APGAR score at 5 minutes and 10 minutes. Birth-related events that might have lead to hypoxic ischemic complications, equals uterine rupture equals severe abruptio placentae equals umbilical cord prolapse equals severe and prolonged maternal hypoxia and hypotension equals maternal cardiovascular collapse equals fetal exsanguination abnormal fetal heart rate monitoring during labor copyright neuroimaging patterns consistent with neonatal hypoxic ischemic brain injury, example watershed cortical injury in MRI. Copyright no evidence of other causes for neonatal encephalopathy, example inborn errors of metabolism, genetic disorders. Further diagnostic measures. Laboratory studies umbilical arterial blood gas analysis, arterial pH, venous pH, base deficit CBC, may show signs of infection, hemorrhage, or thrombocytopenia. Electrolytes, monitoring and treatment guidance. Liver function tests, evaluation of possible damage. Kidney function tests, evaluation of possible damage. Cardiac enzymes, if myocardial injury is clinically suspected. Coagulation tests, in case of bleeding, to exclude disseminated intravascular coagulation. Bacterial blood culture, to exclude neonatal sepsis. Lumbar puncture, if there is clinical suspicion of meningitis/encephalitis. Degree Scent imaging studies. Copyright cranial MRI equals most sensitive tool for detecting hypoxic ischemic injury in the brain to exclude other causes of neonatal encephalopathy equals patterns consistent with high include deep nuclear gray matter injury, parasagittal injury of the cerebral cortex, and watershed cortical injury equals magnetic resonance spectroscopy can be performed additionally. OCNS ultrasound equals alternative if MRI is unavailable, example condition of the newborn, missing resources, but less sensitive for hypoxic ischemic injury. Perfusion measurement and evaluation of morphological changes, example hemorrhages, ventricular size, cerebral edema, severe white matter damage, echocardiography. Equals if myocardial injury is suspected equals may show decreased ventricular contractility, valve dysfunction, or enlargement of the heart EEG. Copyright conducted on the first day of life, continued monitoring for at least 24 hours. OE evaluation of seizure activity and background electrical activity. Asterisk biomarkers. Recent studies indicate that VEGF is significantly increased in neonates that subsequently develop encephalopathy. 8. WA. OE. Treatment. Scent therapeutic hypothermia. 9. Copyright description equals current standard of care for neonates with moderate to severe high equals possible as selective head cooling or systemic hypothermia equals treatment at 33 to 35 degrees Celsius for 72 hours within the first 6 hours of life. Therapeutic window. Copyright eligibility criteria equals gestational age equals 36 weeks and collapse fine text outline. Perinatal asphyxia and hypoxic ischemic encephalopathy plus therapeutic hypothermia degree. Copyright description current standard of care for neonates with moderate to severe high equals possible as selective head cooling or systemic hypothermia treatment at 33 to 35 degrees Celsius for 72 hours within the first 6 hours of life. Therapeutic window. Copyright eligibility criteria equals gestational age equals 36 weeks and Copyright. While maintaining adequate organ perfusion is important in children with high volume overload should be avoided due to the possible subsequent development/worsening of brain edema. And complications. CNS complications. Sent cerebral palsy, most likely spastic quadriplegia or dyskinetic cerebral palsy, periventricular leukomalacia, PVL, sent epilepsy-specific learning disorders ADHD, sent intellectual developmental disorders, sent hearing and/or visual impairment. Other organ complications. Sent heart, impaired myocardial contractility, kidneys, acute renal failure. Mainly conservative treatment necessary. Copyright. Theophylline has a nephroprotective effect. 11-degree dialysis in rare cases. Copyright. Increased risk for the development of chronic kidney disease later in life. Hematopoietic, bone marrow suppression, thrombocytopenia, disseminated intravascular coagulation. Sent liver, elevated transaminase levels, hepatic injury. Sent gastrointestinal tract, necrotizing enterocolitis in case of severe hypoperfusion. Lungs, neonatal respiratory distress syndrome, pulmonary hypertension. We list the most important complications. The selection is not exhaustive. And prognosis. Sent mild encephalopathy, usually normal development, moderate to severe encephalopathy. Copyright. Long-term neurologic manifestations. Copyright. Severe abnormalities seen in MRI and EEG are associated with a poor outcome. Al. Collapse. Fine text outline. XX. The newborn infant. Infants are usually born at term between 37 and 42 weeks of gestation. This time period can be further divided into early term, 37 to 38 weeks, full term, 39 to 40 weeks, and late term, 41 weeks, deliveries. After 42 weeks of gestation, birth is considered post-term. Approximately 10% of births are preterm, occurring prior to 37 completed weeks of pregnancy. Most infants born at term require very little medical attention in order to successfully adapt to extrauterine life. Routine management of a newborn infant immediately after birth consists of removing airway secretions, drying the newborn, and providing him or her with warmth. Healthcare providers also clamp and cut the umbilical cord. The APGAR score is typically used to gauge the clinical status of newborn infants at 1 and 5 minutes after birth using the following parameters: heart rate, respiratory effort, muscle tone, reflex irritability to tactile stimulation, and skin color. Infants who are born at term or late preterm and are breathing and moving satisfactorily should immediately be given to their mother for skin-to-skin contact and initiation of breastfeeding. Infants who are born prematurely, lack muscle tone, or are not breathing or crying may require supplemental oxygen or neonatal resuscitation. Preventive medicine measures in the delivery room include the administration of ophthalmic antibiotics and vitamin K. Within 24 hours of birth, a detailed assessment of the newborn should take place. This typically includes a history of the pregnancy and a physical exam from head to toe, as well as measurements of length and weight. OES. Newborn terminology. General. Sent infant, a child under 1 year of age. FL. Sent newborn, a child under 28 days of age. 2. Sent perinatal period, the period from the 22-week of gestation to the 7-day after birth. 2. And sent postpartum period, first 6 to 8 weeks after birth. Live birth, postnatal presence of vital signs, example respiration, pulse, umbilical cord pulse, for timing of birth. Sent term birth, umbrella term for live births between 37 and 42 weeks of gestation. Early term infant, live birth between 37.0/7 weeks and 38 and 6/7 weeks of gestation. Copyright. Full term infant, live birth between 39.0/7 weeks and 40 and 6/7 weeks of gestation. Late term infant, live birth between 41.0/7 weeks and 41 and 6/7 weeks of gestation plus preterm infant, live birth between 20.0/7 weeks and 36 and 6/7 weeks of gestation, %. 6. Asterisk post-term infant, live birth after the 42-week of gestation evaluation of birth weight. Cent appropriate for gestational age infant, AGA birth weight 10 to 90 percentile for gestational age asterisk small for gestational age infant, SGA birth weight 90 percentile for gestational age low birth weight. O birth weight. Miscarriage, spontaneous abortion, O absence of vital signs, O pregnancy loss before the 20-week of gestation, O fetal weight less than 500 g cent stillbirth, fetal death, O absence of vital signs. Most U.S. states report fetal death if pregnancy loss occurs during or after the 20-week of gestation. O fetal weight more than 500 g. WA. OE. Immediate care and APGAR score. Back collapse, find text outline. Immediate care and APGAR score. Immediate care of the newborn. Wipe the newborn's mouth and nose to clear airway secretions, use suction only if necessary. Dry and stimulate the newborn. Provide warmth. Skin-to-skin contact with mother and initiation of breastfeeding. Clamp and cut the umbilical cord. APGAR score assessment at 1 and 5 minutes after birth. Begin resuscitation if onset of respirations has not yet occurred within 30 to 60 seconds. APGAR score, degree. Plus used for standardized clinical assessment of newborns at 1 and 5 minutes after birth. 1 Copyright 5 components, skin color, heart rate, reflex irritability to tactile stimulation, muscle tone, respiratory effort. Each component is given 0 to 2 points, depending on the status of the newborn. Copyright the total APGAR score is the sum of all 5 components. Cent assessing the need for and beginning neonatal resuscitation should be done independently of and before the APGAR score is determined. 1 Assessment of the APGAR score at 5 minutes, infants with scores. Calculation of the APGAR score. 0 points. 1.2 points. Appearance, skin color, blue, cyanotic, or pale pink trunk, blue extremities, acrocyanosis, pink body and extremities. Pulse, heart rate, none. B and APGAR, appearance, pulse, grimace, activity, respirations. The APGAR score is useful for evaluating the status of a newborn infant, but it should not be used to draw conclusions about individual neonatal morbidity or mortality, and it should not be used as a long-term prognostic tool. Neonatal resuscitation 191L11. Cent high-risk deliveries should have a team of healthcare providers experienced in neonatal resuscitation on hand. Maternal factors, very advanced maternal age or very young maternal age, diabetes or hypertension, substance abuse, previous fetal loss. Fetal factors, prematurity, post-maturity, congenital anomalies, multiple gestations. Copyright complications of pregnancy and delivery, placental anomalies, oligohydramnios/polyhydramnios, transverse/breech delivery, chorioamnionitis, meconium. Stained amniotic fluid, abnormal fetal heart rate, delivery with forceps/vacuum/cesarean. Cent resuscitation steps. Copyright preductal pulse oximetry. Copyright positive pressure ventilation, bag mask ventilation, at a rate of 40-60/minute. Equals indicated if there is inadequate respiratory effort, example gasping, apnea, or a heart rate. Equals at birth, ventilation should be provided with room air for infants 35 weeks gestation. Equals premature infants. O chest compressions equals indicated if heart rate is. Back collapse, find text outline. Preventive measures directly after birth. Cent ophthalmic antibiotics, to prevent gonococcal conjunctivitis, erythromycin ophthalmic ointment, vitamin K, to prevent vitamin K deficiency bleeding of the newborn, VKDB. AID of the newborn. Measurement and a detailed examination of the newborn should take place within the first 24 hours of life. See clinical relevance for examples of pathological findings of a newborn examination. Asterisk measurements copyright, 73 copyright normal range, 10 to 90 percentile at 40 weeks gestation, copyright length, 50 centimeters, 48-53 centimeters, copyright weight, 7% IB, 6 IB, 602 to 8 IB, 9 ounces, 2.9 to 3.9 kilograms, equals boys, 6 pounds, 6 ounces to 8 IB, 9 ounces, 2.9 to 3.9 kilograms, equals girls, 6 pounds, 2 ounces to 8 IB, 6 ounces, 2.8 to 3.8 kilograms, copyright head circumference, 35 centimeters, 33 to 37 centimeters, asterisk vital signs 14, O respiratory rate, 40 to 60 breaths per minute, O heart rate, 120 to 160 beats per minute, cent bilirubin, see neonatal jaundice plus pH, 7.2, slightly more acidic than adults, 15 plus urine and meconium 6 copyright first passage of urine within 24 hours of birth, copyright first passage of meconium, a black-green, tarry substance that forms the newborn's feces, within 48 hours after birth, asterisk feeding, encourage and provide counseling regarding breastfeeding 1. Plus losing weight after birth 17. Copyright loss of up to 7% of birth weight in first 5 days of life is normal and no specific treatment is required. Newborns normally regain their birth weight by the time they are 10 to 14 days old. O for causes of small for gestational age infants, see intrauterine growth restriction. Cent consequences of intrauterine estrogen exposure. O breast bud development is normal in newborns, independent of sex. Copyright newborn girls may have bloody mucoid vaginal discharge. 1. Copyright the physiological respiratory rate and heart rate of newborns are substantially higher than in adults and older pediatric patients. Healthy newborns normally lose up to 7% of their original birth weight in the first 5 days of life. This weight is then gained back through drinking breast milk and formula by age 10 to 14 days. No treatment is necessary. External signs of maturity. Gestational age is estimated at birth with the Ballard score, which combines neuromuscular assessment with the following physical signs of maturity, 118. Sense skin color and texture, rosy body hair, lanugo may be present, thinning, or mostly absent eyes, open ears, well-formed pinna, auricular cartilage, that instantly recoils breast, clearly discernible areola testicles, descended labia, labia minora covered by labia majora, plantar creases, cover the entire solace of the feet. O. OB. Newborn screening. Sent before leaving the hospital, newborns should be screened for serious and life-threatening conditions. Plus the optimal time for screening is 24 to 48 hours after birth. 23 cent screening usually involves assessment for copyright critical congenital cardiac defects, copyright hyperbilirubinemia, copyright congenital deafness, various genetic disorders, example endocrine, metabolic, and hematological disorders. Which genetic disorders to screen for varies according to national and state law, check local guidelines. Back collapse, find text outline. Underscore 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 equals equals s underscore 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 equals s equals underscore underscore overview of screening for newborns 241 I-25. Newborn recommended screening 24-25 conditions to screen recommended ages. Method of screening follows state mandated recommendations on newborn screening. See etiologies on etiological disorders at birth and, in some states, again at 2 weeks of age. In most cases, a capillary heel stick is used to collect dried blood spot samples on filter paper. At equals 24 hours of age and prior to leaving the hospital, a bilirubin level, transcutaneous or serum newborn screening test hyperbilirubinemia. Critical congenital heart defects, CCHD, asterisk at 224 hours of life and / or prior to nursery discharge, simultaneous pulse oximetry of the right hand and foot. All newborns, universal newborn hearing screening prior to otoacoustic emissions, OAE, or automated auditory brainstem response hospital discharge, AABR, congenital deafness 26. Examples of commonly screened genetic conditions. Cent endocrine conditions, copyright congenital hypothyroidism, copyright congenital adrenal hyperplasia, cent metabolic conditions, copyright disorders of fatty acid metabolism, copyright disorders of organic acid metabolism, example isovaleric acidemia, methylmalonic acidemia, propionic acidemia, copyright disorders of amino acid metabolism, example phenylketonuria, homocystinuria, maple syrup urine disease, citrullinemia type, hemoglobinopathies, example sickle cell disease, beta thalassemia, cent other conditions. Degree cystic fibrosis, classical galactosemia, severe combined immunodeficiencies, SCID, glycogen storage disease type IL, Pompe disease, mucopolysaccharidosis type X, linked adrenoleukodystrophy, spinal muscular atrophy, biotinidase deficiency. Degree equals etiology, metabolic disorder that leads to biotin deficiency equals clinical features, dermatitis, CNS damage equals treatment, biotin substitution. WA OIEEE. Clinically relevant neonatal conditions. Skin. Neonatal skin lesions. Head. Head molding, cent caput succedaneum, cent cephalohematoma, cent subgaleal hemorrhage, cent bulging fontanelles as a sign of increased intracranial pressure, facial nerve palsy due to birth trauma. Eyes. Retinopathy of prematuritous, cent newborn conjunctivitis, leukocoria, may indicate retinoblastoma. Ear, nose, and mouth. Cent cleft lip or cleft palate, choanalotresia. Neck and clavicles. Cent birth-related clavicle fracture, cent infant torticollis. Circulatory system. Cent neonatal respiratory distress syndrome, cent cyanotic and acyanotic congenital heart defects. Back collapse, fine text outline. Gastrointestinal tract. Hirschsprung disease, cent necrotizing enterocolitis, cent vitamin K deficiency, bleeding of the newborn urogenital system. Cent congenital adrenal hyperplasia, cent neonatal acute kidney injury, trunk, spine, and extremities. Cent infantile hypotonia, cent neural tube defects, foot deformities, example club foot, metatarsus adductus, cent hip dysplasia, cent brachial plexus injuries. Endocrine organs. Neonatal hypocalcemia, cent congenital hypothyroidism, cent congenital hyperinsulinism, neonatal diabetes, cent congenital hypopituitarism, hematological system. Physiologic anemia of infancy, cent neonatal polycythemia. WI OCE neonatal skin lesions. Erythema toxicum neonatorum. Cent definition, a benign, self-limiting rash that appears within the first week of life. Cent etiology, unknown, probable contributing factors, immature sebaceous glands and / or hair follicles. Cent clinical features, O small, red macules and papules that progress to pustules with surrounding erythema, located on trunk and proximal extremities. O spares the palms of hands and soles of feet. Cent diagnostics, O based on clinical appearance of rash. O biopsy or smear of pustula, rarely necessary. Eosinophils. Cent treatment, observation only. Cent prognosis, typically resolves without complications within 7 to 14 days. Congenital dermal melanocytosis, Mongolian spot. Cent definition, benign blue-gray pigmented skin lesion of newborn. Cent neonatal prevalence 28. Copyright Asian and Native American, 85 to 100% copyright African American, 60% copyright Hispanic, 46 to 70% white. Back collapse fine text outline. Congenital melanocytic nevus. Scent definition: a congenital skin lesion caused by the proliferation of melanocytes plus epidemiology, 1/20,000 births, 30 * clinical features 80. Copyright light to darkly pigmented, well-circumscribed macule or patch AO often with increased hair growth. Copyright vary in size, 20 cm. A nevus larger than 20 cm in size is referred to as a giant congenital melanocytic nevus. A scent treatment, surgical excision or laser ablation, depending on type and size of lesion. Scent prognosis: large nevi are at risk of degeneration. Frequent follow-up. Infantile hemangioma, strawberry hemangioma. Asterisk definition: benign capillary vascular tumor of infancy. Scent epidemiology: copyright occurs in 3 to 10% of infants. 11 more commonly affects girls. Scent pathophysiology: abnormal development of vascular endothelial cells. Copyright rapid proliferation followed by subsequent spontaneous slow involution, occurring at the age of 5 to 8 years. 32 Scent clinical features: O manifests during the first few days to months of life. Copyright progressive presentation, blanching of skin. Fine telangiectasias: red painless papule or macule, strawberry appearance. AAO most commonly on head and neck. Trademark O usually solitary lesions. Scent diagnostics O based on clinical findings. Copyright the differential diagnosis of cherry angioma is found mostly in adults. Scent treatment. Copyright active non-intervention, monitoring, parental education, systemic therapy with propranolol in complicated cases. Rapidly growing cutaneous hemangiomas. Periorbital hemangioma, vascular anomaly in the periorbital region, most commonly the upper eyelid. Hemangiomas in the airways, gastrointestinal tract, or liver. Hemangiomas with high risk of complications. Copyright if unresponsive to medication equals cryotherapy equals laser therapy equals resection if necessary. Scent complications O ulceration. Copyright disfigurement. Scent prognosis O usually good prognosis. Spontaneous resolution is common. Copyright visual impairment if periorbital hemangioma is left untreated. Others. Scent milia neonatorum. Degree definition: tiny epidermal papules caused by the buildup of keratin and sebaceous secretions. Copyright clinical features: pinhead-sized lesions located on the face/trunk. Degree treatment, not necessary. Copyright prognosis: benign skin lesion, spontaneous resolution without scarring. Scent capillary malformations, nevus flammeus, port wine stain, fire mark. Back collapse fine text. O. Outline. Scent capillary malformations, nevus flammeus, port wine stain, fire mark. Degree definition: congenital, benign vascular malformations of the small vessels in the dermis. Epidemiology: may occur in association with a neurocutaneous disorder such as Sturge-Weber syndrome. Copyright clinical features: typically unilateral, blanchable, pink-red patches that grow and become thicker and darker with age. Copyright treatment: cosmetic laser treatment if desired, not necessary. Copyright prognosis: benign skin lesion. Scent. Transient neonatal pilar melanosis, TNPM. Copyright definition: a benign, transient, idiopathic neonatal skin condition. Copyright epidemiology 33. Incidence: 2% most commonly occurs in African American infants, 5%. Copyright clinical features: solitary or clustered pustules and vesicles on a non-erythematous base. A hyperpigmented, erythematous macules and collarettes of fine scale, most commonly affects the forehead, anterior neck, and lower back. O treatment, reassurance. Copyright prognosis: benign, self-limiting skin lesion. Scent nevus anemicus. Copyright definition: a pale patch of skin that does not create erythema in response to trauma, heat, or cold. O etiology: caused by a vascular anomaly, increased sensitivity of cutaneous blood vessels to naturally occurring catecholamines, copyright treatment, not required scent leopard syndrome, Noonan syndrome with multiple lentiginez. Degree lentiginez, lenticular hyperpigmentation, dark macules, electrocardiographic conduction abnormalities, ocular hypertelorism, pulmonary stenosis, abnormalities of genitalia, retardation of growth, deafness. See Noonan syndrome in rare inherited syndromes. Degree scent neonatal acne, scent blueberry muffin syndrome, a descriptive term for neonates born with multiple bluish, purple marks in the skin, which can be due to extramedullary erythropoiesis, purpura, or metastases. Copyright. The differential includes various cancers, example rhabdomyosarcoma, blood disorders, example hemolytic disease of the newborn, and congenital viral infections, example rubella. Some congenital infections may manifest with rashes or other skin conditions and should be differentiated from benign skin lesions in the newborn. Physiologic anemia of infancy. Asterisk definition: a physiologic decrease in RBC production that typically appears at 8 to 12 weeks of age in term infants and 4 to 8 weeks of age in preterm infants. Scent pathophysiology. 34 Copyright. Increase in oxygenation. 7 In tissue oxygen levels. Production of erythropoietin. Copyright. Shorter lifespan of erythrocytes, 60 to 90 days in term infants and 35 to 50 days in preterm infants. Scent clinical features. Copyright. Term infants, typically asymptomatic. Copyright. Preterm infants, rapid decline of HB that may be more severe, often manifesting with pallor, apnea, lethargy, and or poor feeding. Scent diagnostics. Screening for anemia should be performed at 12 months of age via duct measurement of HB levels. 35 Differential diagnoses. Copyright. Blood loss, example due to frequent sampling. Copyright. Increased RBC destruction, example due to immune hemolytic anemia, hereditary spherocytosis, decreased RBC production, example due to congenital hypoplastic anemia. Plus treatment for copyright. Term infants, physiologic anemia is typically well tolerated, no treatment is necessary. Copyright. Preterm infants, treatment is indicated if HB levels are back collapse. Find text outline. A1's neonatal polycythemia. Scent definition: venous hematocrit, HCT, greatly exceeding normal values for gestational and postnatal age. Plus epidemiology: 1 to 5% of newborns. 3 Scent. Scent risk factors: OSGAO infants of diabetic mothers, delayed umbilical cord clamping. Copyright. Intrauterine hypoxia, example maternal tobacco use. Copyright. Twin to twin transfusion syndrome, recipient, chromosomal abnormalities. Scent pathophysiology: maternal hyperglycemia, chronic fetal hyperglycemia. T metabolic effects and oxygen demand equals fetal hypoxemia. 1 Erythropoietin concentrations. Degree delayed umbilical cord clamping, erythrocyte transfusion. FT circulating red blood mass. HCT. Copyright. Placental insufficiency or chronic intrauterine hypoxia, increased intrauterine erythropoiesis. 7 Circulating red blood mass, HCT. Scent clinical features: respiratory distress, cyanosis, apnea. Copyright. Poor feeding, vomiting. Hypoglycemia. Plethora. Lethargy and irritability. Tremors or seizures. Scent diagnostics: venous HCT 65%. Copyright. Hemoglobin 22G/DL. Scent treatment, if symptomatic. Copyright. Monitoring. Copyright. For hydration. Partial exchange transfusion, a procedure in which part of the blood is replaced with an isotonic fluid to lower the hematocrit. Indicated in asymptomatic patients with high hematocrit, 75%, or symptomatic patients with hematocrit 65%. 37 increased risk of NEC. 38 Scent complications: hypoglycemia, hyperbilirubinemia, hyperviscosity syndrome, low iron stores, NEC. S. And neonatal hypoglycemia. Scent definition: low blood glucose in a newborn. Scent subtypes. Copyright. Transitional neonatal hypoglycemia, A normal physiological drop in a newborn's plasma glucose levels within the first 2 hours of life that typically resolves within 72 hours of birth. O persistent neonatal hypoglycemia, low plasma glucose levels. Equals maternal hyperglycemia, fetal hyperglycemia, beta cells hypertrophy and hyperfunctioning fetal and neonatal hyperinsulinemia delivery. Maternal glucose supply, transient hypoglycemia equals insufficient glycogen stores and hyperinsulinemia, impaired hepatic glycogen mobilization. Transient hypoglycemia sent clinical features. O usually asymptomatic. Back collapse, fine text outline. IHE newborn infant. Pathophysiology, copyright inadequate glycogen stores and / or impaired glucose production, copyright increased glucose utilization, maternal hyperglycemia, fetal hyperglycemia, beta cells hypertrophy and hyperfunctioning fetal and neonatal hyperinsulinemia delivery. Maternal glucose supply, transient hypoglycemia equals insufficient glycogen stores and hyperinsulinemia, impaired hepatic glycogen mobilization. Transient hypoglycemia sent clinical features. O usually asymptomatic. O autonomic. Symptoms, example tachycardia, sweating, tremors. Copyright neurological symptoms, example hypotonia, irritability, poor feeding, lethargy, seizures. Asterisk diagnostics, glucose levels should be obtained for symptomatic infants and / or those with known risk factors. 1. 41 421 40 asymptomatic infants, blood sugar levels. Copyright close glucose level monitoring for the first 24 to 48 hours. Copyright oral or for glucose supplementation, if necessary. Plus prognosis 40. Copyright transient hypoglycemia, glucose levels typically increase and stabilize between 45 and 80 mg/dl by the first 72 hours. O persistent hypoglycemia, prognosis depends on the underlying etiology. E7. CE. Lee macrosomia. Scent definition, a fetus that is 4,000 g, 8 IBS 13 ounces, regardless of gestational age. Etiology 43. Degree diabetes mellitus in pregnancy, previous macrosomic fetus, multiparity, maternal obesity, excessive gestational weight gain, maternal birth weight, 4,000 g or 8 IBS 1302, post-term pregnancy, genetic and congenital disorders, example Beckwith-Wiedemann syndrome. Degree plus pathophysiology, 4 degree. O maternal hyperglycemia, fetal hyperglycemia, stimulation of fetal pancreas, fetal hyperinsulinemia. 7 insulin, insulin-like growth factors, growth hormone and other growth factors. 1 fetal growth, fat deposition, hepatic glucose uptake, and glycogen synthesis. 1 delivery to insulin-sensitive tissues, example heart, liver, skeletal muscle. OT maternal lipid levels. T supply of fatty acids to the fetus and fetal hyperinsulinemia, incorporation of fatty acids into fetal adipocytes. 1 fetal adipositas. Scent diagnostics, 4,000 g, 8 IBS 13 ounces, as estimated by ultrasound measurements, example fetal abdominal circumference. Scent complications. O fetal birth injuries, example shoulder dystocia, brachial plexus injury. Acute respiratory distress, transient tachypnea of the newborn, neonatal hyperbilirubinemia, neonatal polycythemia, neonatal hypoglycemia, metabolic acidosis, stillbirth. Long-term complications, example insulin resistance, obesity. O maternal equals genital tract lacerations equals postpartum hemorrhage equals uterine rupture equals protracted or arrested labor. Scent prevention. Copyright individuals with diabetes mellitus in pregnancy should achieve adequate glycemic control. Copyright all pregnant individuals should avoid excessive weight gain. WA. ISIS. Tips and links. Back collapse, fine text. Outline. Intubation of a premature infant born at 23 weeks of gestation VV. Copyright Boss. Hand and foot of a premature infant, in relation to adult fingers, VV. Preterm infant born at 23 weeks of gestation with approximate weight of 500 g. The immature skin is very thin, transparent, and sensitive. Copyright Emboss. Fe/OI/RFZ equals BXX equals EYE equals 4. XI. SEN/22N. 2 thumb encircling hands technique for chest compressions in neonates and infants VV. Recommended technique: if 2 healthcare providers are present, both hands are used to encircle the chest, and chest compressions are performed with both thumbs placed on top of each other over the lower third of the sternum. This technique produces higher coronary artery perfusion pressure than the 2-finger technique and more consistently results in effective compressions. Copyright Emboss. 2-finger technique for chest compressions in neonates and infants. Recommended technique: if only one healthcare provider is present, the chest is compressed using 2 fingers, which are placed on the lower half of the sternum, just below intermammary cleft. In comparison to the 2 thumb encircling hands technique, this allows for faster changes between compressions and delivering breaths when there is only one rescuer. Copyright Emboss. Erythema toxicum neonatorum VV. Foot of a 1-week-old newborn. Multiple papules can be seen on a partially erythematous base. There is also diffuse erythema and scaling of the skin on the outer edge of the foot and between the toes. Source: ID #5168, CDC/Dr. James R. Allen, Centers for Disease Control and Prevention, CDC, licensed under public domain. Congenital dermal melanocytosis, Mongolian spot. A 5 cm, blue-gray macula with irregular borders is visible on the back. The macula has no evidence of hypertrichosis. Copyright Emboss. Congenital melanocytic nevus. Photomicrograph of cross-section of skin sample, H&E stain, high magnification, focal collection of melanocytes within the dermis and enhanced pigmentation of the basal layer of the epidermis can be seen. Single nevus cells extend between collagen bundles. There are no signs of malignant transformation. These findings are consistent with congenital melanocytic nevus, CMN. Source: giant congenital melanocytic nevus with limb hypoplasia and lipomatoses, a rare association by Suvita Arya, Manali Jain, Motilal Bunkar, and Rajendra Thakur, Journal of Pigmentary Disorders, licensed under CC by 4.0. The newborn infant, 4/10. Congenital nevus VV. A prominent congenital nevus with small pronounced melanocytic regions is visible. The nevus displays an irregular margin. Source: ID #13442, CDC/Carl Washington, MD, Emory University School of Medicine, Mona Surya, MD, MPH, Centers for Disease Control and Prevention, CDC, licensed under public domain. The newborn infant, 5/10. Congenital nevus in the intergluteal region. Large congenital nevus. Additional malignancy criteria are the diverse coloration and the slightly irregular margin of the nevus. Source: ID #13441, CDC/Carl Washington, MD, Emory University School of Medicine, Mona Surya, MD, MPH, Centers for Disease Control and Prevention, CDC, licensed under public domain. Congenital melanocytic nevi. Extensive congenital melanocytic nevi in an infant, showing the characteristic variable coloration. Source: ID #13443, CDC/Carl Washington, MD, Emory University School of Medicine, Mona Surya, MD, MPH, Centers for Disease Control and Prevention, CDC, licensed under public domain. The newborn infant, 7/10. Infantile hemangioma. Dome-shaped, crusted, red nodule on the lower left eyelid of a child. Two smaller nodules can be seen above the left eye and on the forehead. These lesions are also referred to as strawberry hemangiomas and are usually located on the head and neck region. Copyright emboss. Euro the newborn infant, 8/10. Infantile superficial hemangioma. The scalp has a solitary, ovoid, bright red nodule with irregular texture. This finding is suggestive of superficial hemangioma. Source: Hemangioma, Spa-Mercanal, Wikimedia Commons licensed under public domain. Port wine stain, Nevus flammeus. A sharply demarcated, irregularly configured, erythematous area with a smooth surface on the left side of this 2-month-old infant's face is visible. Image source of original image, www.pediatry-in-builder-n.de. Created by Dr. Thomas Rotten-Strock. Modifications to original image, anonymized. Transient neonatal pustular melanosis. Multiple pustules and erosions are visible on this neonate's trunk. Source: Transient neonatal pustular melanosis 1.jpg by GZZZ, Wikimedia Commons, licensed under CC by SA 4.0. Birth traumas. Birth trauma is an injury to the newborn caused by mechanical forces during birth. Risk factors include macrosomia, abnormal fetal presentation, prolonged or rapid labor, and forceps or vacuum deliveries. Soft tissue injuries of the scalp include benign cephalohematoma and caput succedaneum, as well as subgaleal hemorrhages, which are associated with a high risk of significant blood loss and require monitoring. The most common skeletal injury is the clavicle fracture, which is often asymptomatic and heals spontaneously within 7 to 10 days. Skeletal or muscular birth injuries may cause torticollis, a unilateral contraction of the sternocleidomastoid muscle with a resulting head tilt. Other birth injuries include nerve damage, such as brachial plexus injury and facial nerve palsy, which may cause temporary muscle weakness or paralysis. The prognosis of birth traumas is usually favorable, with most injuries resolving spontaneously within weeks to months. CE. Risk factors. Scent macrosomia or anatomical abnormalities. Scent extremely premature infants, low birth weight, abnormal fetal presentation, copyright breech presentation, copyright shoulder dystocia plus forceps assisted delivery or vacuum delivery, scent prolonged or rapid labor, scent small maternal stature. References, IL2. CE. Neonatal soft tissue injuries. Soft tissue injuries of the scalp in infants are mostly caused by shearing forces during vacuum or forceps delivery. Head molding. Copyright transient deformation of the head into an elongated shape due to external compression of the fetal head as it passes through the birth canal during labor. Copyright typically resolves within a few days after the birth. Caput succedaneum, benign edema of the scalp tissue that extends across the cranial suture lines. Firm swelling, pits if gentle pressure is applied. No treatment required, resolves within hours or days. Cephalohematoma, subperiosteal hematoma that is limited to cranial suture lines. Trademark. Copyright complications, calcification of the hematoma, secondary infection. No treatment required, resolves within several weeks or months. Subgaleal hemorrhage, rupture of the emissary veins and bleeding between the periosteum of the skull and the aponeurosis that may extend across the suture lines. Copyright associated with a high risk of significant hemorrhage and hemorrhagic shock. TIIERDA = OD. References: 3IL4I. CE. Birth-related clavicle fracture. Scent epidemiology, most common fracture during birth, 2% of deliveries, plus etiology, Ill copyright mostly occurs during normal labor and delivery. O may be associated with high birth weight, example due to macrosomia. Scent clinical features. O usually asymptomatic. 1 Copyright possible pseudoparalysis. Copyright bone irregularities, crepitus, and tenderness over the clavicle possible on palpation. Copyright possible brachial plexus palliae v. Back collapse. Fine text outline. Scent diagnostics, clinical diagnosis, X-ray only indicated in cases of gross bone deformation. Scent treatment. O reassurance and promote gentle handling of the arm, example while dressing. Copyright to avoid discomfort, pin shirt sleeve to the front of the shirt with the arm flexed at 90 degrees. Copyright consider analgesics. O follow up 2 weeks later to confirm proper healing, via clinical findings of a callus formation, and possibly an X-ray. O usually self-resolves within 2 to 3 weeks without surgical intervention or long-term complications. References: W.A. OA5. Infant torticollis. Scent definition: twisted or rotated neck caused by contraction of the sternocleidomastoid muscle, can be acquired or congenital. Congenital muscular torticollis, pathomechanism of acquired torticollis. Copyright sternocleidomastoid or trapezius muscle injury. Copyright cervical muscle spasm. Copyright cervical nerve irritation. Pathomechanism of congenital torticollis. Copyright not fully understood, likely from muscular or skeletal injury during delivery with subsequent fibrosis and contracture of the sternocleidomastoid muscle. O associated with, equals intrauterine constraint, which causes unilateral shortening of the sternocleidomastoid muscle. Equals oligohydramnios. Equals multiple gestation. Equals macrosomia. Equals decreased fetal movement. Equals breech presentation. Equals assisted vaginal delivery. Scent clinical features: E head noticeably tilted to one side with the chin rotated towards the opposite side. Co-muscular tightness, limited passive range of motion. Copyright potentially palpable thickening of the SCM+. Scent conditions associated with congenital torticollis. O developmental dysplasia of the hips. Copyright brachial plexus palsy. Copyright clubfoot. Copyright craniofacial asymmetry. Scent differential diagnosis: postural preference, vertebral anomalies, absence of cervical musculature, ocular anomalies, underlying conditions, example spina bifida. Scent treatment. Copyright early initiation of physiotherapy, passive positioning. O surgery at 12 months of age if conservative management is insufficient, myotomy or bipolar release of the affected SCM. Scent complications: craniofacial asymmetry, positional plagiocephaly, scoliosis of the cervical spine. References: /1. W.A. O5. Facial nerve palsy due to birth trauma. Epidemiology: most common cranial nerve injury during birth. Scent pathomechanism. Copyright injury occurs during forceps-assisted delivery, most common. Copyright prolonged birth in which the head is pressed against the maternal sacral promontory. Scent clinical features: O peripheral facial nerve palsy, difficulty feeding, incomplete eye closure, absent nasolabial folds. Scent treatment: eye care with artificial tears and ointment. Scent prognosis: spontaneous recovery in 90% of cases within several weeks. Back collapse. Fine text outline. Birth traumas. Laid, TADE 1. Scent definition: twisted or rotated neck caused by contraction of the pathomechanism of acquired torticollis, can be acquired or congenital, congenital muscular torticollis. Copyright sternocleidomastoid or trapezius muscle injury. Copyright cervical muscle spasm. Copyright cervical nerve irritation. Pathomechanism of congenital torticollis. Copyright not fully understood, likely from muscular or skeletal injury during delivery with subsequent fibrosis and contracture of the sternocleidomastoid muscle. Copyright associated with, equals intrauterine constraint, which causes unilateral shortening of the sternocleidomastoid muscle. Equals oligohydramnios. Equals multiple gestation. Equals macrosomia. Equals decreased fetal movement. Equals breech presentation. Equals assisted vaginal delivery. Scent clinical features: O head noticeably tilted to one side with the chin rotated towards the opposite side. E muscular tightness, limited passive range of motion. Copyright potentially palpable thickening of the SCM scent conditions associated with congenital torticollis EO developmental dysplasia of the hips. Copyright brachial plexus palsy. Copyright clubfoot. Copyright craniofacial asymmetry. Differential diagnosis, postural preference, vertebral anomalies, absence of cervical musculature, ocular anomalies, underlying conditions, example spina bifida. Scent treatment. Copyright early initiation of physiotherapy, passive positioning, copyright surgery at 12 months of age if conservative management is insufficient, myotomy or bipolar release, of the affected SCM. Complications, craniofacial asymmetry, positional plagiocephaly, scoliosis of the cervical spine. References / 4a. CE. Facial nerve palsy due to birth trauma. Scent epidemiology. Most common cranial nerve injury during birth. Pathomechanism. Injury occurs during forceps-assisted delivery, most common. Copyright prolonged birth in which the head is pressed against the maternal sacral promontory. Scent clinical features. Peripheral facial nerve palsy, difficulty feeding, incomplete eye closure, absent nasolabial folds. Scent treatment, eye care with artificial tears and ointment. Prognosis, spontaneous recovery in 90% of cases within several weeks. OS. CE. Neonatal brachial plexus palsy. Excessive lateral traction on the neck during delivery. Injury to the upper trunk of the brachial plexus. Herb palsy, most common iatrogenic brachial plexus injury during delivery. Scent excessive traction on the arm during delivery. Injury to the lower trunk of the brachial plexus. Klumpke palsy. Scent prognosis, approximate 25% of affected infants experience persistent functional impairment. Brachial plexus injury is associated with shoulder dystocia, which more commonly leads to Herb palsy than Klumpke palsy. Back collapse. Fine text outline. Birth traumas, 1/3. Cutis subcutis periosteum. Epicranial aponeurosis. Periosteum. HL parietal bone % end parietal bone. Dura mater. Normal arachnoid mater. Cephalohematoma. Cutis subcutis. Parietal bone and epicranial aponeurosis. Dura mater. Epicranial aponeurosis. Dura mater at periosteum. Arachnoid mater. I. Subgaleal hematomas. Subdural hemorrhage. Birth head injuries. VV. Caput succedaneum is an edema of the scalp tissue located between the epicranial aponeurosis and the cutis. Cephalohematoma is a subperiosteal hematoma and is therefore located between the skull and periosteum. A subgaleal hemorrhage is located between the periosteum and epicranial aponeurosis. Copyright emboss. Cephalohematoma, 1/2. Head of an infant born at term. There is swelling over the right parietal bone with boundaries limited to cranial suture lines. These findings are highly suggestive of a cephalohematoma, which is caused by a subperiosteal hemorrhage as a result of trauma sustained during birth. Copyright emboss. Birth traumas, 3/3. Cephalohematoma, 2/2. Head of an infant born at term. There is swelling over the right parietal bone with boundaries limited to cranial suture lines. These findings are highly suggestive of a cephalohematoma, which is caused by a subperiosteal hemorrhage as a result of trauma sustained during birth. Copyright emboss. Birth traumas, 1/1. Congenital torticollis. A limited range of passive motion. Normal. Head tilted, / towards ALD affected SCM. J chin rotated by away from IA affected SCM. So _ palpable _ neck mass. Congenital torticollis. VV. Congenital torticollis is caused by fibrotic contraction of the sternocleidomastoid, SCM, muscle, resulting in neck flexion towards the affected SCM and neck rotation towards the opposite side. Physical examination typically shows limited passive range of motion, limited rotation and flexion of the neck. If left untreated, congenital torticollis can result in craniofacial asymmetry. Copyright on Boss. XX peripheral nerve injuries. Peripheral nerve injuries result from systemic diseases, example diabetes, autoimmune disease, or localized damage, example trauma, compression, tumors, and manifest with neurological deficits distal to the level of the lesion. They occur as isolated neurological conditions or, more commonly, in association with soft tissue, vascular, and/or skeletal damage. Peripheral nerve injury can cause sensory deficits, loss of motor function, or a combination of both. Diagnosis is based on clinical evaluation, imaging techniques, X-ray, CT/MRI, and electrodiagnostic examination, example nerve conduction study, EMG. Observation and conservative treatment, example activity modification, splinting, electrical stimulation, are indicated in most closed injuries, which have a high rate of spontaneous recovery. Patients with open injuries or long disease courses may require surgical treatment. Recovery from peripheral nerve injury is often incomplete and patients may experience chronic pain. VA-RE, EXO. Types of nerve fibers. Nerve fiber overview. Nerve fibers: myelinati impule, DITY, M/S, afferent fibers LA, primary afferent fibers of the muscle spindle AA, LA, IB, *100, *IB, Golgi tendon organ. Scent pressure and fine touch sensations of 2, *50. X2 secondary afferent fibers of the muscle spindle present IA20 colonase none. Somatic pain as 3, copyright 15 temperature sense. B7 none. Mechanoreceptors C, 4, plus absent E1 scent visceral pain polymodal. OOE. Types of nerve damage. Classification of peripheral nerve injury is useful for determining the prognosis and choosing a treatment strategy. Neuropraxia. Compression injury causing temporary disruption of nerve conduction. Scent the whole nerve remains structurally intact. Scent good prognosis with complete recovery of nerve function. Axonotomesis 5. Scent the axon is damaged but the perineurium and epineurium remain intact. Leads to central chromatolysis. Scent definition: the reaction of a neuronal cell body in response to an axonal injury. Scent function: increase in protein synthesis to help restore the integrity of the damaged axon. Scent characteristics: O swelling of the neuronal body. Copyright dispersion of the Nislo bodies. Copyright displacement of the nucleus to the periphery. Results in Wallerian degeneration. Scent definition: an active neuronal degeneration process in response to axonal injury. Scent function: O to clear axonal debris and prevent scarring. Copyright facilitate targeted reinnervation and functional recovery of tissues previously innervated by that axon before injury. Scent characteristics. Copyright initially retained electrical excitability of axonal membrane distal to the injury, lasting up to 36 hours. Progressive degeneration of distal segment cytoskeleton with dissolution of axonal membrane. O. Degradation of residual myelin sheath by macrophages and Schwann cells. Copyright the proximal stump either stays in place or retracts slightly. Copyright ultimately, the cell body will sprout regenerative nerve fibers that, ideally, reinnervate the distal tissues. Regeneration is significantly more efficient in the peripheral nervous system than in the central nervous system. Copyright good chance of at least partial recovery. V. Efferent fibers. Motor neurons. None. Muscle spindle. Dorsal root fibers. Preganglionic sympathetic fibers. Postganglionic sympathetic fibers. AL. Outline. Neurotomesis. Scent complete nerve transection. Scent connective sheath damage. Scent the chances of recovery are very poor without surgical repair. Traumatic neuroma. Plus benign, painful nodular thickening caused by nerve regeneration at the site of different forms of nerve injury. And nerve injuries in the upper body. Brachial plexus injuries, IL-3. Herb palsy. Scent injury to the upper trunk of the brachial plexus, C5-C6, scent etiology O excessive lateral flexion of the neck A** trauma, example falling on the head and shoulder in a motorcycle accident, birth injury, excessive lateral traction on the neck during delivery and shoulder dystocia, scent clinical features O weakness of muscles in the C5 and C6 myotomes equals flexed wrist with an extended forearm and internally rotated and adducted arm, waiter's tip posture, equals weak biceps brachii. Brachialis, and brachioradialis impaired flexion and supination of the forearm absent biceps reflex weak infraspinatus and supraspinatus impaired external rotation of the arm equals weak deltoid and supraspinatus impaired arm abduction equals weak wrist extensors impaired wrist extension O asymmetric Moro reflex in infants, absent or impaired on the affected side, copyright sensory loss in the C5 and C6 dermatomes, thumb and lateral surface of the forearm and arm, scent treatment. Degree immobilization in flexion and external rotation with an abduction brace. Copyright physiotherapy O surgery for severe nerve damage or prolonged cases. QB for weakened muscles in Erb's palsy, imagine birds eating herbs served by a waiter, biceps brachii, infraspinatus, wrist extensors, deltoid, supraspinatus, waiter's tip posture. Klumpke palsy. Plus injury to the lower trunk of the brachial plexus, C8T1, copyright etiology O hyperabduction of the arm equals trauma, example breaking a fall by grabbing a branch, equals birth injury, excessive upward traction on the arm during delivery copyright compression of the lower trunk of brachial plexus, subacute to chronic onset, equals Pancoast tumor equals cervical rib scent clinical features. Back collapse fine text outline. Scent clinical features. A weakness of intrinsic hand muscles, thenar, hypoth of the metacarpophalangeal joints in the hand, O preganglionic Horner syndrome if injury occurs proximal to the white ramus comune icons O decreased peripheral pulses if subclavian vessels are compressed by a Pancoast tumor or cervical rib, C thoracic outlet syndrome, O absent grasp reflex in infants copyright sensory loss in the C8 and T1 dermatomes, little finger and medial surface of the forearm and arm. Scent treatment. Copyright splinting the hand to correct the claw hand O physiotherapy O surgery for severe nerve damage. Peripheral nerve injuries in the upper extremity. NAR, lumbricals, interossei, total claw hand, persistent flexion of the interphalangeal joints and extension. Distal nerve lesions are more likely to cause claw deformities, example ulnar claw or median claw, because they result in a loss of lumbrical function with intact extrinsic flexors 1 cent in proximal nerve lesions. Hand distortions, example Pope's blessing, are only visible when the patient tries to flex the fingers or make a fist. Injured nerve roots. Axillary nerve injury J*SE6. Scent C5 musculocutaneous nerve C7 injury equals. Radial adia nerve injury *BTH. Scent C5 median nerve injury 1. Recurrent branch of *CS median nerve injury T1. *C8 ulnar nerve injury 171. Back. Overview of peripheral nerve injuries in the upper extremity. Common causes. Anterior shoulder dislocation. Fracture of surgical neck of the humerus laterogenic, example shoulder reconstruction procedures, rotator cuff surgery, osteosynthesis of humeral fractures, compression due to mass in the axilla, example nodular fasciitis, schwannoma. Trauma upper trunk compression, example Erb palsy. Compression of the radial nerve, most common, within the axilla copyright crutch palsy Saturday night palsy mid-arm, mid-haft fracture of the humerus wrist degree radial fracture wearing tight bracelets or handcuffs degree repeated supination/pronation, example screwing movements. Proximal injury, supracondylar fracture of humerus distal injury copyright carpal tunnel compression copyright wrist laceration, suicide attempt. Pronator teres syndrome, compression of the median nerve between the humeral and ulnar heads of the pronator teres. Superficial palm laceration. Proximal injury fracture of medial epicondyle of the humerus, funny bone, cubital tunnel syndrome distal injury ulnar tunnel syndrome, from cycling, ganglion cysts, copyright hook of hamate fracture, typically from falling on an outstretched hand. Motor deficits. Paralysis of the deltoid muscle impaired arm abduction, 15 degrees, paralysis of the teres minor muscle impaired external rotation of the arm muscle atrophy, flattened deltoid A. Paralysis of brachialis and coracobrachialis muscles impaired elbow flexion. Paralysis of biceps brachii impaired forearm supination reduced biceps reflex, C5-C6. Axillary injury, impaired forearm extension at elbow, wrist drop. Mid-arm injury, wrist drop for grip strength, maximal flexion can only be achieved when the wrist is extended. Atrophy of thenar muscles impaired flexion of wrist, thumb, index, and middle finger proximal injury, above the anterior interosseous nerve origin, copyright hand of benediction, when trying to make a fist, copyright ulnar deviation upon wrist flexion distal injury, below the anterior interosseous nerve origin median claw, when extending the fingers, deep injury to the wrist or forearm impairing the thenar muscles functions, ape hand positive pinch sign in anterior interosseous nerve syndrome. Ape hand atrophy of thenar muscles, impaired flexion, abduction, and opposition of the thumb. Ulnar claw, mainly in distal nerve injuries, L. Wartenberg sign Froment sign proximal injury copyright radial wrist deviation when flexing copyright inability to flex the ring finger and little finger impaired flexion of wrist and medial fingers sent impaired adduction/abduction of fingers. Collapse. Interossei muscles, impaired lumbrical muscle action of the little finger and ring finger. Fine text. Sensory deficits. Sent lower part of the deltoid region and lateral arm 1. Sent lateral forearm, from the elbow to the base of the thumb J. Asterisk dorsal arm and forearm sent hand, dorsal aspect of the thumb, index, and the middle fingers. Sent proximal injury copyright thenar eminence o palmar aspect of thumb, index, and middle fingers, lateral ring finger sent distal injury, same as proximal injury. Sent no sensory deficits. Sent palmar and dorsal aspects of the little finger, medial half of ring finger, and hypothenar eminence. Outline. Peripheral nerve injuries in the cervicothoracic region. Overview of peripheral nerve injuries in the cervicothoracic region. Injured nerve peen innervat muscles common causes motor deficits. Asterisk C3 equals asterisk elevation of the diaphragm on the side of the phrenic nerve injury sent diaphragm sent C phrenic nerve paralysis 7ZCS nerve lesion pulmonary and cardiac function. Sent compression copyright entrapment of the nerve within the suprascapular _ H asterisk limited adduction, abduction, and external rotation of the degree C forearm suprascapular nerve asterisk infraspinatus and supraspinatus copyright paralabral ganglion cyst, injury C6FFPF sent shoulder instability, due to paralysis of rotator cuff copyright thickening and / or bony ossification of the overlying less, muscle superior transverse scapular ligament asterisk major or repetitive trauma 1. Dorsal scapular CS sent rhomboid major, rhomboid sent isolated injury is uncommon 1 fan 10 nerve injury minor, Levator scapulae usually accompanies injury to the scalene muscle cetera G. angus. As plus, sun sip oueae sectinarn winged scapula, medial scapula protrudes from the long thoracic nerve degree C5 cerivescent anon mastectum Y, injury C7 asterisk stab wounds asterisk impaired abduction of the arm beyond 90 degrees carrying a heavy backpack for a long time. Latissimus dorsi, limited shoulder retraction, impaired thoracodorsal nerve asterisk C6 latissimus dorsi, teres major surgery in the inferior part of the axilla or on scapular adduction, and internal rotation of the arm injury C8 lymph nodes teres major, limited internal rotation and adduction of the arm. BNB diaphragm innervation, C3, 4, 5 keep the diaphragm alive. Phrenic nerve paralysis. The anatomical course of the nerve copyright originates as a branch from the cervical plexus of C3-C5O passes ventrally on the anterior scalene muscle before descending into the chest wall. O runs between pleura and pericardium accompanied by pericardiac phrenic artery and vein. Copyright supplies motor innervation of the diaphragm and sensory innervation of the pericardium, parietal pleura, mediastinal and diaphragmatic part, and peritoneum. Sent etiology. O unilateral equals trauma equals latrogenic, example. Cardiac surgery, equals compression, example malignancy. O bilateral equals motor neuron diseases, example amyotrophic lateral sclerosis, equals neuropathies, example Guillain-Barré syndrome, post-polio syndrome, equals cervical spine surgery equals trauma equals tumor. Sent clinical features. Copyright unilateral paralysis equals often asymptomatic equals exertional dyspnea possible. O bilateral paralysis, severe dyspnea. Sent diagnostics. O unilateral phrenic nerve paralysis equals auscultation equals decreased respiratory movement equals dull on percussion equals CXR equals ipsilateral diaphragmatic elevation equals possibly mediastinal shift equals compression atelectasis. Back collapse. Find text outline. Peripheral nerve injuries equals compression atelectasis equals fluoroscopy, paradoxical elevation of the paralyzed hemidiaphragm on respiration or on asking the patient to sniff, sniff test. O bilateral phrenic nerve paralysis equals spirometry, decreased vital capacity equals diaphragmatic electromyography. Sent treatment. Mechanical ventilation may be required. Copyright possible implantation of a diaphragmatic pacemaker. B. Fal. ZB. A. Nerve injuries in the lower body. Overview of nerve injuries in the lower body. Nerve common causes roots injured nerve. Latrogenic injury during abdominal open surgery. Leo-hypogastric nerve degree Hertz injury L1. Genitofemoral nerve *Lee injury L2. Latrogenic injury during abdominal laparoscopic surgery. Compression at the level of the inguinal ligament, caused by, copyright increased intra-abdominal pressure, example pregnancy, uterine fibroids, obesity, ascites, external compression, from, example tight belts, pants, or compression dressings, trauma to the anterior superior iliac spine, local compression, due to, example tumors, muscle compression from prolonged sitting or standing, hematomas. Degree lateral femoral cutaneous nerve injury, neuralgia paresthetica. EES L3. Degree. Pelvic surgery. Diabetic lumbosacral plexopathy direct injury, example pelvic fracture, knife injuries, gunshots, latrogenic, pelvic, abdominal, or spinal surgery, femoral line placement prolonged pressure on the nerve, psoas degree EE hematoma, aortic or iliac aneurysms, or L4 tumors. Femoral nerve injury. Pelvic surgery internal compression, E.G., due to thickened obturator fascia, tumors, obturator hernias, external compression, example due to pelvic ring fractures. Obturator nerve injury. Laterogenic injury from intramuscular superior gluteal nerve equals *B injection in the upper medial gluteal region injury $1.00. Superficial peroneal nerve, stretch trauma, example ankle sprains, facial defects degree L4 $2 common peroneal nerve fracture of the fibular head compression, tight casts, sitting cross. Legged, lithotomy position during surgery 4. Back. Motor deficits. Impaired contraction of lower parts of transversus abdominis and internal oblique. Paralysis of cremaster, 1 cremasteric reflex. None. Paralysis of iliopsoas, pectineus, rectus femoris, and sartorius muscles impaired hip flexion paralysis of quadriceps femoris muscle impaired knee extension and decreased patellar tendon reflex. Scent paralysis of hip adductors, adductor longus, adductor brevis, adductor magnus, obturator externus, gracilis, pectineus. Plus paralysis of gluteus 2 and fascia lata impaired hip abduction * positive Trendelenburg sign, lateral pelvic drop. Tensor. Towards the opposite, healthy, side 4. Superficial peroneal nerve, paralysis of peroneus longus and peroneus brevis impaired eversion of the foot * deep peroneal nerve, paralysis of foot and toe extensors, dorsiflexors, example tibialis anterior, leading to, copyright foot drop o steppage gait. WV equals A. Collapse fine text. Sensory deficits. Lateral hip suprapubic region in iatrogenic injury, burning or tingling sensation radiating to regions innervated by the injured nerve. Anterior scrotum / labia majora upper anterior and medial thigh, lateral femoral triangle, caudal of inguinal ligament. Neuralgia paresthetica, pain and paresthesias on the lateral surface of the anterior thigh. Copyright can be improved by wearing looser clothing and / or losing weight. Pain in the inguinal region, pain relieves during external rotation and flexion of the hip, anterior cutaneous branches, anteromedial thigh. Saphenous nerve lesion, medial lower leg, knee, example infrapatellar pain, medial edge of the foot eye. Hausch-Bromberg sign, pain and paresthesia over the inner aspect of the thigh 4. None. Superficial peroneal nerve, lateral surface of the lower leg, dorsum of the feet and toes, except for the space between the first and second toe. Deep peroneal nerve, area between the first and second toes, flip-flop zone. A. Outline. Sciatic nerve injury. Degree L4 $3 tibial nerve injury. Sural nerve injury. Inferior gluteal nerve cent E65 injury $2. Herniated lumbar disc posterior hip dislocation laterogenic, misplaced intragluteal injection, direct trauma, gun and / or stab wounds, total hip arthroplasty, 5. Trauma of the knee or leg, E.G. Tibial fracture, Baker's cyst, causes proximal lesion, tarsal tunnel syndrome, causes lesion of the posterior tibial nerve. Achilles tendon rupture entrapment neuropathy, example crural fascia thickening, A7 ganglion lipomas. Posterior hip dislocation. Paralysis of hamstring muscles, semimembranosus, semitendinosus, biceps femoris, and adductor magnus impaired knee flexion and hip adduction * sciatic nerve splits into tibial nerve and common peroneal nerve motor deficits of muscles innervated by these nerves. Paralysis of biceps femoris, long head, paralysis of foot flexors, example triceps suri, inability to stand on or curl toes and to invert foot proximal lesions, eversion of the foot at rest. None. Paralysis of GLI impide thigh extension difficulty standing up from a sitting position and climbing stairs backward lurching gait, an abnormal gait in which the trunk tilts backward while walking during the heel strike phase of the limb with the weak hip extensor forward pelvic tilt. Lower leg and foot A. Sensory loss over sole of the foot, see Morton Neuroma for more information. Posterolateral side of the lower leg, lateral border of the foot, small area under the heel. None. Differences between tibial nerve and peroneal nerve injuries: tip plus tibial impaired foot inversion and plantar flexion plus peroneal impaired foot eversion and dorsiflexion. Diagnostics. The diagnosis of peripheral nerve injuries is based on a thorough clinical history, neurological examination, and, in some cases, diagnostic tests, example X-ray if fracture is suspected. Scent imaging, copyright plain X-ray, detection of compression or transection due to dislocated bone or fracture segments, copyright CT/MRI, evaluation of causes like nerve tumors, avulsions, and focal soft tissue pathologies, scent electrodiagnostic studies, detect and grade nerve injury, nerve compression, and identify early stages of recovery, copyright electroneurography, nerve conduction study, analysis of a muscle's electrical activity in response to stimulation of its supplying nerve, needle electromyography. EMG. A degree. Management. Conservative treatment, 61. Splinting, 71. Copyright prevents stiffness and contractures of joints, copyright supports residual nerve functionality and reinnervation physiotherapy. Analgesia, non-opioid analgesics, example NSAIDs, copyright infiltration with local anesthetics. Drug therapy. Expectant management, example closed injuries of the nerve with a high rate of spontaneous recovery. Activity modification, example avoid sports or activities that increase the likelihood of further nerve injury. Copyright treatment of chronic neuropathic pain following peripheral nerve injury, example gabapentin. 9. Copyright used in combination with surgical treatment to enhance remyelination and motor regeneration, example lithium, HO. Back. Equals A. Collapse, find text. Electrical stimulation supports the regeneration of the proximal axons and reinnervation of the denervate muscles after surgical nerve repair. 8. O. Outline. X. Peripheral nerve injuries. Asterisk paralysis of GL, impaired thigh extension, difficulty standing up from a sitting position and climbing stairs. L5 reigns $2. Cent posterior hip dislocation, backward lurching gait, an abnormal gait in which none the trunk tilts backward while walking during the heel strike phase of the limb with the weak hip extensor forward pelvic tilt. Differences between tibial nerve and peroneal nerve injuries: tip plus tibial impaired foot inversion and plantar flexion plus peroneal impaired foot eversion and dorsiflexion. S. Diagnostics. The diagnosis of peripheral nerve injuries is based on a thorough clinical history, neurological examination, and, in some cases, diagnostic tests, example X-ray if fracture is suspected. Scent imaging, copyright plain X-ray, detection of compression or transection due to dislocated bone or fracture segments. OCT/MRI, evaluation of causes like nerve tumors, avulsions, and focal soft tissue pathologies. Electrodiagnostic studies, detect and grade nerve injury, nerve compression, and identify early stages of recovery. Copyright electroneurography, nerve conduction study, analysis of a muscle's electrical activity in response to stimulation of its supplying nerve. Copyright needle electromyography. EMG. WI. OXO. Management. Conservative treatment. 6. Expectant management, example closed injuries of the nerve with a high rate of spontaneous recovery. Activity modification, example avoid sports or activities that increase the likelihood of further nerve injury. Asterisk splinting. 7. Copyright prevents stiffness and contractures of joints. Copyright supports residual nerve functionality and reinnervation physiotherapy. Scent electrical stimulation supports the regeneration of the proximal axons and reinnervation of the denervate muscles after surgical. Nerve repair. 8. Analgesia. Copyright non-opioid analgesics, example NSAIDs, O. Infiltration with local anesthetic scent drug therapy. Copyright treatment of chronic neuropathic pain following peripheral nerve injury, example gabapentin. 9. Copyright used in combination with surgical treatment to enhance remyelination and motor regeneration, example lithium. 19. Surgical repair. Scent indications. Copyright open, non-contaminated, sharp injuries and concomitant vascular injuries. Immediate surgical exploration and repair. Copyright open, contaminated injuries and post-reduction palsy. Early surgical exploration and repair, within 3 weeks. O. Patients without clinical or electromyographic signs of spontaneous recovery. Delayed surgical exploration and repair, within 3 months. Scent procedures. O. Nerve repair, neuropathy. Reconstruction of nerve continuity. O. Nerve transfer. An intact healthy nerve is redirected towards a denervate nerve in order to restore the innervation of its target organ. Copyright tendon transfer. A tendon from a sufficiently powerful muscle is redirected towards another tendon in order to restore its motion and function. Back collapse. Fine text outline. Peripheral nerve injuries, 1/2. Nucleus. Nus. Substance. Macrophage. Axon, Schwann cell. IJ. Phagocytosis. Traction force. Myelin debris. Regenerative nervous fibers. Wallerian. 4. Degeneration. O == registered. Axonatomesis VV. Copyright Boss. Europeripheral nerve injuries, 2/2. Essay. Chromatolysis VV. Microscopy of the anterior horn of the spinal cord, H&E stain. Neurons undergoing chromatolysis tend to have an enlarged cell body with a rounder shape and exhibit displacement of the nucleus and the Nislo substance towards the periphery. Source: Central Chromatolysis, Intermed Mag, cropped by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Europeripheral nerve injuries, 1/16. Herb palsy, upper trunk injury. E////on. SS waiter's tip posture and SNNX_ internally rotated / and adducted arm NQ / extended and pronated forearm flexed wrist 1. Brachial plexus injuries, herb palsy and Klumpke palsy. Copyright Boss. Klumpke palsy, lower trunk injury. We see SA. Clohan deformity _ SJG. MCP joints extended. IP joints flexed. Herb palsy, waiter's tip posture, V. The affected right arm is in adduction and internal rotation, with the forearm extended and pronated. These features are characteristic of herb palsy. The wrist and fingers are typically also flexed in this condition, but the child's clothing makes assessment of the degree of flexion difficult here. Source: Fig. 1, in Oberlin partial ulnar nerve transfer for restoration in obstetric brachial plexus palsy of a newborn, case report by Shigematsuke, Yahima H., Kobata Y., et al., Journal of Brachial Plexus and Peripheral Nerve Injury, licensed under CC by 2.0. As peripheral nerve injuries, 3/16. Clinical features of C5 and CE6 nerve root injury. Adduction, due to weak deltoid palsy of the axillary and PND storcina i.e. suprascapular nerves. Intimal rotation. Due to weak infraspinatus. Extension due to weak biceps brachii. Palsy of the musculocutaneous nerve. Pronation due to weak biceps brachii and brachioradialis. Impaired wrist extension due to weak wrist extensors. Waiter's tip deformity in herb palsy VV. Copyright Boss. Brachial plexus VV. A. Upper trunk B, lower trunk C, long thoracic nerve D, posterior cord E, axillary nerve F, radial nerve G, musculocutaneous nerve H, median nerve I, ulnar nerve. Copyright Boss. Europeripheral nerve injuries, 5/16. Klumpke palsy, lower brachial plexus injury. Horner syndrome, meiosis, ptosis, anhidrosis. Weakness of intrinsic hand muscles, absent grasp reflex. Claw hand deformity. Klumpke palsy VV. Copyright Boss. Supraclavicular nerves. Axillary nerve, superior lateral cutaneous nerve. Radial nerve, inferior lateral cutaneous nerve. Equals intercostobrachial nerve and medial brachial musculocutaneous * cutaneous nerve, lateral antebrachial medial antebrachial cutaneous nerve, cutaneous nerve. Radial nerve. Median nerve OE. Ulnar nerve. Sensory innervation areas of the peripheral nerves, arm, ventral view, VV. Copyright Boss. Europeripheral nerve injuries, 7/16. Supraclavicular nerves. Axillary nerve, superior lateral cutaneous nerve. Degree radial nerve, inferior lateral cutaneous nerve, intercostobrachial nerve / and medial brachial cutaneous nerve musculocutaneous nerve medial antebrachial, lateral antebrachial cutaneous nerve. Radial nerve ulnar nerve. Median nerve. Sensory innervation areas of the peripheral nerves, arm, dorsal view, VV. Copyright Boss. / up / impaired external rotation impaired arm abduction / trademark of the arm over 15 degrees clinical finding, deltoid muscle atrophy, Duyal Albi law, due to paralysis of deltoid muscle. Clinical features of axillary nerve injury. Copyright Boss. _N at sensitivity, affected regions. 04F/\IA. Motor function, proximal Q, CA, distal yet. Wrist drop lesion VEMD. Radial nerve neuropathy VV. Motor deficits, wrist drop, inability to extend, dorsiflex, the wrist, inability to extend the fingers at the MCP joints. Sensory deficits, dorsal aspect, radial 2% fingers, less commonly, 3% fingers, excluding the tips of the 2 and 3 fingers. The $1 T-web space is the autonomous sensory zone of the radial nerve and is highlighted in red. Palmar aspect, the radial border of the thumb. Proximal lesion, complete loss of motor and sensory function. Distal lesion, radial tunnel syndrome, partial loss of motor function, preservation of sensory function. Copyright Boss. Europeripheral nerve injuries, 10/16. Proximal median nerve lesions, above ulnar nerve origin. Hand of benediction, Pope's blessing, when patient tries to make a fist. Distal median nerve lesions, below ulnar nerve origin. Median claw when patient tries to extend fingers. Proximal and distal lesions. WTHVA /DH// if /F4A/4, //YJ, W //SX, SA//SXEO. Normal bottle sign when patient holds cylindrical object. Proximal and distal median nerve lesions. Ulnar nerve, anterior interosseous nerve. Copyright Boss. Europeripheral nerve injuries, 11/16. Thenar atrophy secondary to median nerve injury. Atrophy of the left and right thenars, abductor pollicis brevis and opponens pollicis muscles, secondary to bilateral carpal tunnel syndrome. Source, copyright IMPP. Europeripheral nerve injuries, 12/16. Sensitivity, affected regions. Motor function, Froment sign. _proximal Q, distal motor function, claw-hand lesion and lesion registered. Ulnar nerve neuropathy VV. Motor deficits, claw-hand. The 4 and 5 joints are hyperextended at the MCP and flexed at the IP joints at rest, neutral position. Froment sign, the patient is asked to grasp a piece of paper between the thumb and the index finger. When the examiner tries to pull the paper away, the thumb flexes at the IP joint because the flexor pollicis longus, supplied by the median nerve, compensates for the paralyzed adductor pollicis, supplied by the ulnar nerve. Also depicted here is hollowing of the intermetacarpal spaces and the one's web space due to the atrophy of the interossei, which is seen in chronic ulnar nerve palsy. Sensory deficits, dorsal aspect, ulnar 2% fingers, less commonly, 1% fingers, excluding the tips of the 3 and 4 fingers, palmar aspect, ulnar 1% fingers. Proximal lesion, complete loss of motor and sensory functions. Uroperipheral nerve injuries, 12/16. Sensitivity, affected regions. Motor function, Froment sign. Proximal Q, distal motor function, claw-hand lesion and lesion registered. Ulnar nerve neuropathy VV. Claw-hand. The 4 and 5 joints are hyperextended at the MCP and flexed at the IP joints at rest, neutral position. Froment sign, the patient is asked to grasp a piece of paper between the thumb and the index finger. When the examiner tries to pull the paper away, the thumb flexes at the IP joint because the flexor pollicis longus, supplied by the median nerve, compensates for the paralyzed adductor pollicis, supplied by the ulnar nerve. Also depicted here is hollowing of the intermetacarpal spaces and the 1st web space due to the atrophy of the interossei, which is seen in chronic ulnar nerve palsy. Sensory deficits, dorsal aspect, ulnar 2% fingers, less commonly, 1% fingers, excluding the tips of the 34 and 4 fingers, palmar aspect, ulnar 1% fingers. Proximal lesion, complete loss of motor and sensory functions. Distal lesion, complete loss of motor function, preservation of sensory function. Uroperipheral nerve injuries, 13/16. Medial winging of the scapula. When the patient is asked to place both palms against a wall and push, the medial border of the right scapula is abnormally prominent. This is the characteristic appearance of scapular winging. It indicates a palsy of the serratus anterior, which is most commonly due to an injury of the long thoracic nerve. Source, Fig. 4, in isolated long thoracic nerve paralysis, a rare complication of anterior spinal surgery, a case report by Ameri E., Batash H., Omidi Kashani F., Journal of Medical Case Reports, licensed under CC by 2.0. Uroperipheral nerve injuries, 14/16. Medial winging of the scapula VV. The medial border of the left scapula is abnormally prominent. Medial winging of the scapula is caused by paralysis of the serratus anterior muscle, most commonly secondary to an injury of the long thoracic nerve. Source, Figure 1b, in overlooked fracture of the inferior scapular angle treated conservatively by Ogawa K., Inakuchi W., Hanma T., Hindawi, Case Reports in Orthopedics, licensed under CC by 4.0. Modifications, image cropped. Peripheral nerve injuries, 15/16. Left phrenic nerve. Overlay. Elevation of the left hemidiaphragm from phrenic nerve paralysis 1/2 VV. X-ray chest, PA view, 2 discrete masses are visible in the right lung, green overlay. The hyla are enlarged and lobulated, suggesting bilateral lymphadenopathy, red overlay. There is atelectasis, yellow overlay, adjacent to elevation of the left hemidiaphragm, white line, suspicious for phrenic nerve paralysis. Gaseous dilatation of bowel, B, is also seen in the left upper quadrant, and the mediastinum is slightly shifted to the right, indicated by arrows. Blue overlay, top right corner hardware left humerus source, copyright IMPP. Further notes, illustration added to overlay, source, Fig 7, in, surgical approaches to supradiaphragmatic segment of IVC and right atrium through abdominal cavity during intravenous tumor thrombus removal by Dmitros Chikin, Vladimir Lisovoy, Igor Garagati, Gennady Kariba, Ridwan Sain, Advances in Urology, licensed under CC by 3.0. Uroperipheral nerve injuries, 16/16. Overlay. Elevation of the left hemidiaphragm from phrenic nerve paralysis 2/2 VV. X-ray chest, lateral view, there is elevation of the left hemidiaphragm, dashed line, with adjacent atelectasis, yellow overlay, of lung parenchyma and underlying dilated bowel, B. Blue overlay, hardware left humerus, solid line, right hemidiaphragm source, copyright IMPP. Uroperipheral nerve injuries, 16/16. Overlay. Elevation of the left hemidiaphragm from phrenic nerve paralysis 2/2 VV. X-ray chest, lateral view, there is elevation of the left hemidiaphragm, dashed line, with adjacent atelectasis, yellow overlay, of lung parenchyma and underlying dilated bowel, B. Blue overlay, hardware left humerus, solid line, right hemidiaphragm source, copyright IMPP. Uroperipheral nerve injuries, 1/5. Leo-hypogastric nerve plus leo-inguinal nerve plus genitofemoral nerve * UF lateral femoral cutaneous nerve plus femoral nerve plus obturator nerve plus 1 intermediate dorsal cutaneous nerve. T medial dorsal cutaneous nerve saphenous nerve - deep fibular nerve common fibular nerve * deep fibular nerve - plus T dorsal digital nerve, branch to medial side of second toe, plus dorsal digital nerve superficial fibular nerve plus, branch to lateral side of great toe, lateral dorsal cutaneous nerve OT, from sural nerve. Innervation of the lower extremity, ventral view, V. The femoral nerve is the main nerve of the anterior compartment of the thigh. The saphenous nerve and the medial and intermediate cutaneous nerves of the thigh originate from the femoral nerve. The obturator nerve is the main nerve of the medial compartment of the thigh and exits the pelvis ventrally through the obturator foramen. The iliohypogastric, ilioinguinal, genitofemoral, and lateral femoral cutaneous nerves are pure sensory nerves that arise directly from the lumbar plexus. The common fibular nerve, a terminal branch of the sciatic nerve, branches into the superficial and deep peroneal nerves at or just below the neck of the fibula. Cutaneous innervation of the foot is supplied by the saphenous nerve medially and the sural nerve laterally. Cutaneous innervation of the dorsum of the foot is supplied by branches of the superficial fibular nerve, with the exception of the first interdigital space, which is supplied by a branch of the deep fibular nerve. Aranase. Peripheral nerve injuries, 2/5. Iliohypogastric nerve lateral cutaneous branch. Genitofemoral nerve femoral branch. *_leo-inguinal nerve. Page pudendal nerve genital branch equals dorsal nerve of penis. Lateral femoral cutaneous nerve **/ femoral nerve anterior cutaneous branches obturator nerve. At common peroneal, fibular, nerve lateral sural cutaneous nerve. AE \femoral nerve \saphenous nerve \, superficial fibular nerve, sural nerve J. Deep fibular nerve plus. Innervation areas of the peripheral nerves, leg, ventral view. Copyright Boss. SS leo-hypogastric nerve medial lateral cutaneous branch cluneal nerves. Posterior femoral cutaneous nerve inferior cluneal nerves. Lateral femoral cutaneous nerve femoral nerve anterior cutaneous branches. 7 posterior femoral cutaneous nerve. Obturator nerve. Common fibular nerve, lateral sural cutaneous nerve, tibial nerve, medial sural cutaneous nerve, femoral nerve, saphenous nerve, tibial nerve, calcaneal branches, sural nerve, tibial nerve, medial plantar nerve, tibial nerve, lateral plantar nerve. Innervation areas of the peripheral nerves, leg, dorsal view, VV. Copyright Emboss. Peripheral nerve injuries, 4/5. / anterior compartment. FLA, tibialis anterior muscle, tibia fib extensor, hallucis longus muscle, FLE extensor digitorum longus muscle, ID deep fibular nerve, anterior tibial vein and artery, saphenous A nerve, great saphenous vein, lateral compartment. Fibularis longus muscle, fibularis brevis muscle, 2C superficial fibular nerve. Deep posterior compartment, fibula 3A tibialis posterior muscle, BB flexor hallucis longus muscle, 3C, flexor digitorum longus muscle, 3D fibular vein and artery, 3E tibial nerve, posterior tibial vein and artery. A superficial posterior compartment. 4A soleus muscle, 4B gastrocnemius muscle, lateral head. Sural nerve, small saphenous vein. Ad gastrocnemius muscle, medial head. Ostofascial compartments of the leg, VV. Transverse section of the right leg, caudal view. The interosseous membrane and deep facial septa divide the leg into 3 compartments, 1 anterior, extensor, compartment, bound by the tibia and the anterior intermuscular septum, junction of blue and purple compartments, 2. Lateral, fibular, compartment, bound by the anterior and posterior intermuscular septum, junction of purple and green compartments, 3. Posterior, flexor, compartment, which is further divided into, deep posterior compartment, bound by the interosseous membrane anteriorly, junction of blue and orange compartments, and the transverse intermuscular septum posteriorly, junction of orange and green, superficial posterior compartment, posterior to the transverse intermuscular septum. Copyright Emboss. Uroperipheral nerve injuries, 5/5. Trendelenburg and Duchenne signs, VV. The Trendelenburg sign indicates insufficiency of the gluteus medius and gluteus minimus muscles. It is tested for as follows: 1. The pelvic level is assessed by comparing the height of both iliac crests. 2. The patient is asked to stand on one leg, with the examiner continuously observing the level of the pelvis and the patient's posture. Normally, the pelvis is stabilized by the gluteus medius and gluteus minimus muscles, which prevent a pelvic drop to the opposite side. 3. In the case of muscle insufficiency, the pelvis drops towards the unimpaired, unsupported side, free leg, which is known as the Trendelenburg sign. 4. Tilting of the torso toward the contralateral side compensates for the pelvic drop on the unimpaired side, which is known as Duchenne sign. Because the Duchenne sign may mask the Trendelenburg sign, it is important to always inspect the patient's overall posture. Copyright Emboss. X. Neonatal respiratory distress syndrome. Neonatal respiratory distress syndrome, NRDS, or surfactant deficiency disorder, is a lung disorder in infants that is caused by a deficiency of pulmonary surfactant. It is most common in preterm infants, with the incidence and severity decreasing with gestational age. Surfactant deficiency causes the alveoli to collapse, resulting in impaired blood gas exchange. Symptoms manifest shortly after birth and include tachypnea, tachycardia, increased breathing effort, and or cyanosis. Suspected diagnosis is based on clinical features and confirmed by evaluating the extent of atelectasis via an X-ray of the chest. Blood gases show respiratory and metabolic acidosis in addition to hypoxia. Treatment primarily involves emergency resuscitative measures, including nasal continuous positive airway pressure, CPAP, and the stabilization of blood sugar levels and electrolytes. Intratracheal surfactant should be administered if infants require an increased FiO, to maintain a sufficient oxygen saturation despite receiving non-invasive positive pressure ventilation. Intratracheal surfactant should be administered if ventilation alone is unsuccessful. Most cases resolve within 3 to 5 days of treatment. However, complications such as hypoxemia, tension pneumothorax, bronchopulmonary dysplasia, or sepsis may still occur. In rare cases, NRDS may lead to neonatal death. NRDS can be prevented by administering antenatal glucocorticoids to the mother if premature delivery is expected. WA. CE. Etiology. Neonatal respiratory distress syndrome is caused by impaired synthesis and secretion of surfactant. Risk factors include, premature birth, maternal diabetes mellitus, leads to 1 fetal insulin, which inhibits surfactant synthesis * hereditary 61, cesarean delivery, results in lower levels of fetal glucocorticoids than vaginal delivery, in which higher levels are released as a response to stress from uterine contractions. Hydrops fetalis e multifetal pregnancies male sex. WA. CE. Epidemiology. Incidence 2 copyright 1% of all newborns copyright 10% of all preterm babies. The risk of developing NRDS depends on gestational age. 50% copyright greater than 37 weeks of gestation. Co. 05. Pathophysiology. Surfactant/31. Pulmonary surfactant is a mixture of phospholipids and proteins produced by lamellar bodies of type II alveolar cells. These phospholipids reduce alveolar surface tension, preventing the alveoli from collapsing. Surfactant deficiency is most likely to occur in preterm infants, because surfactant production begins at approximately 20 weeks gestation. Copyright distribution throughout the lungs begins at 28 to 32 weeks gestation and does not reach sufficient concentration until 35 weeks gestation. Surfactant deficiency. Little or no reduction of alveolar surface tension, increased alveolar collapse, atelectasis, decreased lung compliance and functional residual capacity, hypoxemia and hypercapnia. Hypoxemia and hypercapnia, vasoconstriction of the pulmonary vessels, hypoxic vasoconstriction, and respiratory acidosis. Intrapulmonary right to left shunt, increased permeability due to alveolar epithelial damage, fibrinous exudation within the alveoli, development of hyaline membranes in the lungs. Hyaline membrane disease. Back collapse, fine text outline. Clinical features. Maternal history of premature birth. Onset of symptoms, usually immediately after birth but can occur up to 72 hours postpartum. Signs of increased respiratory effort, tachypnea, nasal flaring and moderate to severe subcostal/intercostal and jugular retractions. Characteristic expiratory grunting. Decreased breath sounds on auscultation. Cyanosis due to pulmonary hypoxic vasoconstriction. Reference/4. GU2. Diagnostics. Physical examination, see clinical features above. Maternal history, previous preterm birth. X-ray chest. Copyright interstitial pulmonary edema with perihilar streaking. Copyright diffuse, fine, reticulogranular, ground glass, densities with low lung volumes and air bronchograms. Copyright atelectasis. Blood gas analysis. Hypoxia with respiratory acidosis, may lead to increased lactate levels. Evaluate for partial respiratory failure or global respiratory failure. Amniocentesis for prenatal testing of NRDS, screening for markers of fetal lung immaturity. Copyright lecithin-sphingomyelin ratio equals a semi-quantitative test used to assess fetal lung maturity. Amniotic fluid is mixed with ethanol until foam formation ceases to occur. The index refers to the highest quantity of ethanol that can be added to amniotic fluid, still permitting the formation of foam. Low surfactant albumin ratio *. Histological findings, 5. Hyaline membranes lining the alveole equals composed of fibrin, cellular debris, and red blood cells equals eosinophilic appearance, amorphous material lining the alveolar surface O engorged and congested capillary vessels in the interstitium. References, 2IL6LL7 and differential diagnoses. Pulmonary hypoplasia O underdevelopment of the lungs characterized by a decreased number of alveoli and small airways and reduced lung volumes in one or both lobes O results in impaired gas exchange and severe respiratory distress that may require intubation. Copyright associated with congenital diaphragmatic hernia, usually left-sided, oligohydramnios, and Potter sequence * congenital diaphragmatic hernia 1 cent pneumothorax, dash. Plus neonatal pneumonia. Overview of NDRDS and its differential diagnoses. Transient tachypnea of the persistent pulmonary equals 4 Hall 11 characteristics. Neonatal respiratory, apnea of prematurity, AOP, newborn, wet lung disease, hypertension of the new by AE distress syndrome is, ppHN, 91H2. Most commonly term and mast emanifiel term. Back collapse. Fine text outline. Ch-istics. Term. Etiology. Risk factors. Onset of symptoms. Clinical features. Imaging. Treatment. Complications. RESPY distress syndrome. Preterm. Deficiency of pulmonary surfactant. Preterm delivery. Male sex. Maternal diabetes. Within the first minutes/hours after birth. Tachypnea. Increased breathing effort. Cyanosis. Hypoxia. Decreased breathing sounds. Diffuse, fine, reticulogranular, ground glass, densities. Low lung volumes and air bronchograms. Supportive care. Nasal CPAP. Endotracheal administration of artificial surfactant. Bronchopulmonary dysplasia. Pneumothorax. PDA. Apnea of prematurity, AOP. Immature respiratory control. Preterm delivery, 1 extremely low birth weight. Within 2 to 3 days after birth. Episodes of breathing pauses, usually 20 seconds, that are frequently accompanied by hypoxemia and/or bradycardia. Usually not necessary, since AOP is a clinical diagnosis of exclusion. Imaging may be used to rule out other causes of apnea, example sepsis, intracranial hemorrhage. Supportive care, example supplemental oxygen, neutral thermal environment, maintaining a physiological neck position, avoidance of excessive nasal suctioning, nasal CPAP. Methylxanthine therapy, example caffeine, theophylline. Resolves without complications in the majority of cases at approximate 43 to 44 weeks of postmenstrual age. The differential diagnoses listed here are not exhaustive. Treatment. Plus ventilation. O nasal CPAP with a PEEP of 3 to 8 cm H01. O if respiratory insufficiency persists, start intubation with mechanical ventilation and Oz inhalation. A. Transient tachypnea of the newborn MOE disease, 8. Most commonly full-term and near-term infants. Delayed resorption and clearance of fetal lung fluid. Caesarean delivery, especially before the onset of labor. 1 delivery before 39 weeks gestation. Maternal asthma. Maternal diabetes. Small for gestational age infant. Male sex. A13 macrosomia. Immediately after birth and within the next 2 hours. Tachypnea. Increased breathing effort. Diffuse crackles, diminished or normal breathing sounds on auscultation. Fluid in the lung fissures and increased lung volumes. Supportive care, example supplemental oxygen, neutral thermal environment, adequate nutrition. Resolves without complications in the majority of cases. Sent endotracheal administration of artificial surfactant within 2 hours postpartum. 1 supportive measures, 4 fluid replacement, stabilization of blood sugar levels and electrolytes. Persistent pulmonary overview of NDRDS and its differential diagnoses. Yen hypertension of the IB, PPHN, 91. Most commonly term and preterm infants, can also occur in post-term infants. Elevated pulmonary vascular resistance. Perinatal asphyxia, prolonged premature rupture of the membranes, infection, meconium aspiration syndrome. Within 24 hours after birth. Low APGAR scores, cyanosis and signs of respiratory distress, heart examination, prominent precordial impulse and a narrowly split and accentuated S. Pulmonary hypertension on echocardiography. Supportive care, continuous pulse oximetry screening 1, for severe cases, inhaled nitric oxide last resort, ACMO. Severe PPHN. Copyright developmental delay, copyright motor deficit, copyright hearing deficit. 2. Most commonly post-term. 011. Intrauterine passage of meconium and aspiration leading to airway obstruction. Post-term delivery, non-reassuring fetal heart rate tracing, perinatal asphyxia, placental insufficiency, oligohydramnios, cesarean delivery, maternal hypertension and diabetes, maternal infection / chorioamnionitis. Immediately after birth. Green amniotic fluid, low APGAR score, tachypnea, increased breathing effort, hypoxia, lung rales and rhonchi. Increased lung volumes, asymmetric, patchy opacities, pleural effusion. Supportive care, example supplemental oxygen administration, 1, continuous pulse oximetry, severe cases, standard steps of neonatal resuscitation, inhaled nitric oxide, administration of surfactant. Persistent pulmonary hypertension of the newborn, PPHN, pneumothorax, pneumomediastinum. Copyright Physiologico, saturation in neonates is around 90%. A saturation of 100% is considered toxic for neonates. Go. Yes ed no. Complications. Back. NAL. Collapse. A. Find text. O. Outline. X. Neonatal respiratory distress syndrome. Treatment. Plus ventilation. O. Nasal CPAP with a PEEP of 3 to 8 cm H010. If respiratory insufficiency persists, start intubation with mechanical ventilation. NO. Inhalation. BA sent endotracheal administration of artificial surfactant within 2 hours postpartum. 1 cent supportive measures, for fluid replacement, stabilization of blood sugar levels and electrolytes. At. Physiologic. O. Saturation in neonates is around 90%. A saturation of 100% is considered toxic for neonates. WA. OES. Complications. Bronchopulmonary dysplasia, BPD, 15. Scent definition, chronic lung condition secondary to prolonged mechanical ventilation and oxygen therapy for NRDS. Scent etiology, pulmonary barotrauma and oxygen toxicity with subsequent inflammation of lung tissue due to ventilation of the immature lung, ventilation for more than 28 days. Scent clinical features. O. Seen in infants. Pneumothorax, dash. Scent hypoxia, patent ductus arteriosus. The persistently low partial pressure of oxygen in the blood contributes to PDA. Scent cardiovascular arrest, neonatal sepsis. Scent complications of 0, inhalation, retinopathy of prematurity, bronchopulmonary dysplasia, intraventricular hemorrhage. And baby oxen have ribs. Babies receiving too much oxygen get retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. We list the most important complications. The selection is not exhaustive. 7. CE. Prognosis. Asterisk mortality rate. ZG Fe, XE. Prevention. Prevent premature birth if possible. Cetocolysis. Antenatal corticosteroid therapy administered to the mother, stimulates infant lung maturation, 17E given 48 hours before delivery. 2 doses of IM betamethasone 24 hours apart or 4 doses of IM dexamethasone 12 hours apart. B. Back collapse. Find text outline. Surfactant deficiency. \expiration II8, alveolar collapse. Decreased alveolar expansion. A5 equals Phe. Alveolar collapse in surfactant deficiency. VV surfactant reduces alveolar surface tension. In surfactant deficiency, increased surface tension results in increased alveolar collapse during expiration and decreased alveolar expansion during inspiration. Copyright Boss. A neonatal respiratory distress syndrome, 2 halves. OSL CNGIEIM. ETAED, EE equals E, ME OEF sub Z. OM1 PTHY and F. 8. AWG. YFA SER. Overlay. Hyaline membranes in ARDS VV. Photomicrograph of lung tissue, HNE stain, 400x magnification. The alveolar walls are lined by eosinophilic hyaline membranes, example indicated by green overlay. The normal basophilic alveolar epithelial lining is absent. Within the interstitium, there is an extensive inflammatory infiltrate, which is visible as numerous basophilic nuclei, large basophilic nuclei, macrophages, multilobed nuclei, neutrophils. There are numerous microthrombi, visible as extracapillary aggregates of RBCs. The capillaries appear congested. Loss of alveolar epithelium, presence of alveolar hyaline membranes, and interstitial inflammation, edema, and congestion are the typical features of the acute exudative phase of ARDS. Source: Hyaline membranes, Intermed Mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. A neonatal respiratory distress syndrome, 2 halves. HAEECRFFNI is EAEEOE 478, S het. IP. Beheagness equals OAHEA, AVLEA, 4S% 0.04, E422 AGSS. T equals UE. Overlay. Hyaline membranes in ARDS VV. Photomicrograph of lung tissue, HNE stain, 400x magnification. The alveolar walls are lined by eosinophilic hyaline membranes, example indicated by green overlay. The normal basophilic alveolar epithelial lining is absent. Within the interstitium, there is an extensive inflammatory infiltrate, which is visible as numerous basophilic nuclei, large basophilic nuclei, macrophages, multilobed nuclei, neutrophils. There are numerous microthrombi, visible as extracapillary aggregates of RBCs. The capillaries appear congested. Loss of alveolar epithelium, presence of alveolar hyaline membranes, and interstitial inflammation, edema, and congestion are the typical features of the acute exudative phase of ARDS. Source: Hyaline membranes, Intermed Mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Neonatal respiratory distress syndrome, 2/6. RTRD Ray plus, BES BAT -3 ETO EER. Overlay. Neonatal respiratory distress syndrome. X-ray chest, frontal view, of a premature infant. The lungs are opacified and have a granular appearance. Air bronchograms, green overlay, extend to the lung periphery. An endotracheal tube, red outlines, is well positioned above the carina. In neonatal respiratory distress syndrome, RDS, surfactant deficiency results in alveolar collapse and non-compliant lungs. Air bronchograms are visible when aerated bronchi and bronchioles are surrounded by a cinar atelectasis. Source: copyright IMPP. Neonatal respiratory distress syndrome, 2/6. Overlay. Neonatal respiratory distress syndrome. X-ray chest, frontal view, of a premature infant. The lungs are opacified and have a granular appearance. Air bronchograms, green overlay, extend to the lung periphery. An endotracheal tube, red outlines, is well positioned above the carina. In neonatal respiratory distress syndrome, RDS, surfactant deficiency results in alveolar collapse and non-compliant lungs. Air bronchograms are visible when aerated bronchi and bronchioles are surrounded by a cinar atelectasis. Source: copyright IMPP. Neonatal respiratory distress syndrome, 4/6. Neonatal respiratory distress syndrome. X-ray chest of a premature infant. Source: Figure 1, in 2 mutations in surfactant protein C gene associated with neonatal respiratory distress by Tarocco A, Ballardini E. Contiero MR, ETAL, Hindawi, Case Reports in Pediatrics, licensed under CC by 3.0. Modifications, image cropped. Neonatal respiratory distress syndrome, 5/6. Overlay. Respiratory distress syndrome, 2/3, VV. X-ray chest, AP view, a right tension pneumothorax has developed. It is accompanied by depression of part of the right hemidiaphragm, indicated by red line and arrow, and leftward shift of the mediastinum, indicated by blue line and arrow. The right lung, green overlay, is partially collapsed. A chest tube has been placed in the lower hemithorax, and endotracheal and nasogastric tubes are present. There is a left central line. Copyright Emboss. Neonatal respiratory distress syndrome, 5/6. Copyright. Overlay. Respiratory distress syndrome, 2/3. X-ray chest, AP view, a right tension pneumothorax has developed. It is accompanied by depression of part of the right hemidiaphragm, indicated by red line and arrow, and leftward shift of the mediastinum, indicated by blue line and arrow. The right lung, green overlay, is partially collapsed. A chest tube has been placed in the lower hemithorax, and endotracheal and nasogastric tubes are present. There is a left central line. Copyright Emboss. Neonatal respiratory distress syndrome, 6/6. Overlay. Respiratory distress syndrome, 3/3. X-ray chest, AP view, the right tension pneumothorax surrounding the lung has increased in size despite chest tube placement, and lung collapse, green overlay, has worsened. There is increased leftward shift of the mediastinum, indicated by blue line and arrow, and depression of part of the right hemidiaphragm, indicated by red line and arrow. An endotracheal tube, nasogastric tube, and right central line are shown. Copyright Emboss. Neonatal respiratory distress syndrome, 6/6. Copyright. Overlay. Respiratory distress syndrome, 3/3. X-ray chest, AP view, the right tension pneumothorax surrounding the lung has increased in size despite chest tube placement, and lung collapse, green overlay, has worsened. There is increased leftward shift of the mediastinum, indicated by blue line and arrow, and depression of part of the right hemidiaphragm, indicated by red line and arrow. An endotracheal tube, nasogastric tube, and right central line are shown. Copyright Emboss. Necrotizing enterocolitis. Necrotizing enterocolitis, NEC, is a dangerous hemorrhagic inflammation of the intestinal wall that most often affects premature infants. Typical symptoms include abdominal distension, gastric retention, tenderness, rectal bleeding, and visible intestinal loops lacking peristalsis. A radiographic finding of gas within the wall of the intestine, pneumatosis intestinalis, confirms the suspected diagnosis. Conservative management of the condition involves parenteral nutrition and antibiotics. In the case of advanced NEC and intestinal perforation, however, surgery is necessary. OO/OES. Definition: hemorrhagic necrotizing inflammation of the intestinal wall most commonly affects the distal ileum and proximal colon. OODER. Epidemiology. SENT NEC is the most common cause of acute abdomen in premature infants. Peak incidence, 2-4 week after birth. 2 Epidemiological data refers to the U.S., unless otherwise specified. Etiology. SENT. The causes of necrotizing enterocolitis are not fully understood, but multiple factors contribute to the development of the condition. O. Intestinal wall perfusion and motility disorders. Copyright defective or underdeveloped immune system. Copyright intestinal microbial overgrowth. O. Formula feeding. O. Rapid increase of enteral nutrition. References SLL Altzalil. VA. OE Red Notes. Clinical features. Bell staging criteria. Stage diagnosis. Symptoms. Stage suspected NEC. Lethargy, distended and shiny abdomen, gastric retention, vomiting, diarrhea, rectal bleeding. Stage IL** proven NEC** stage symptoms plus abdominal tenderness, visible intestinal loops lacking peristalsis plus intestinal perforation, symptoms of sepsis, flank redness. Stage ill advanced NEC, Z** if left untreated, rapid progression to disseminated intravascular coagulation, DIC, and shock. References /IL8L. OOOE. Diagnostics. Laboratory tests. SENT complete blood count, O neutrophil counts. X necrotizing enterocolitis. Diagnostics. Laboratory tests. SENT complete blood count, O neutrophil count. C disseminated intravascular coagulation. SENT arterial blood gas analysis. Metabolic acidosis is associated with advanced NEC. SENT blood culture. Imaging, degree 1. SENT abdominal radiography. O pneumatosis intestinalis, bubbles of gas within the wall of the intestine. Copyright portal venous gas, pneumatosis hepatis, O increased intestinal wall thickness. Copyright dilated intestinal loops, 1 O air fluid levels. O pneumoperitoneum as a result of intestinal perforation. SENT abdominal ultrasound. Copyright indication, ultrasound may be helpful for diagnosing NEC when abdominal radiography is inconclusive. O findings equals pneumatosis intestinalis equals portal venous gas equals increased intestinal wall thickness equals decreased intestinal wall perfusion. References 10LL11121T8I13. OIEEE. Differential diagnoses. Diff-EL of Ising-litis ional obstruction features NEC on perf, infectious enterithes food protel N-induced colitis. Distended abdomen. Symptoms abdominal pain NM-PI, abdominal pain 5 vomiting SENT hypotension OE bloody stools rectal bleeding J vomiting crepitus. X-ray and ultrasound, pneumatosis other intestinalis SENT first week after birth plus failure to pass positive stool. 2. 7 cow's milk specific IgE findings SENT after the first week and after feeding was independent of feeding meconium cultures begun. AE Kate Cal MSA E references, 4IL15. The differential diagnoses listed here are not exhaustive. Treatment. Back collapse. Fine text outline. X necrotizing enterocolitis. PE references 14LL15. The differential diagnoses listed here are not exhaustive. OUR CE. Treatment. Treatment should be initiated promptly when NEC is suspected to prevent complications such as perforation, peritonitis, and sepsis. Send supportive care. Copyright stop enteral feeding, parenteral feeding and substitution of fluids or gut decompression via nasogastric tube for broad-spectrum antibiotics, example ampicillin, gentamicin, and metronidazole for anaerobic coverage. Sent radiographic monitoring, plain supine abdominal radiographs every 6 to 12 hours in the initial phase of the disease. Sent surgery, primary peritoneal drainage and/or laparotomy with necrotic bowel excision. Copyright indications, perforation, peritonitis, and/or clinical worsening despite medical therapy. References, 1L17. By 2 shared notes. Complications. Sent intestinal perforation, abdominal radiography, pneumoperitoneum treatment, surgery. Sent short bowel syndrome. Sent peritonitis. Sent sepsis. 1 References 71. We list the most important complications. The selection is not exhaustive. 7 FO, IEEE. Prognosis. Mortality rate, approximate 10 to 30%. References, Ali 9. *ST. Prevention. Breast milk has a protective effect. 1. Overlay. Necrotizing enterocolitis. X-ray abdomen, AP view, supine, of a neonate. Multiple distended bowel loops in the right hemiabdomen are accompanied by small lucencies indicating the presence of intramural gas, pneumatosis intestinalis. Pneumatosis intestinalis is a feature of necrotizing enterocolitis. It can appear as bubbly, green overlay, curvilinear, yellow overlay, or linear, red overlay, lucencies on an abdominal radiograph. Source, Necrotizing Enterocolitis 202 by RadsWiki, RadsWiki, licensed under CC by SA 3.0. Further notes, original source page no longer online but can be found under https://web.archive.org/web/2010616344/http/radswiki.net/main/index.php. Title equals file necrotizing_enterocolitis_202.jpg. Overlay. Necrotizing enterocolitis v. X-ray abdomen, AP view, supine, of a neonate. Multiple distended bowel loops in the right hemiabdomen are accompanied by small lucencies indicating the presence of intramural gas, pneumatosis intestinalis. Pneumatosis intestinalis is a feature of necrotizing enterocolitis. It can appear as bubbly, green overlay, curvilinear, yellow overlay, or linear, red overlay, lucencies on an abdominal radiograph. Source, Necrotizing Enterocolitis 202 by RadsWiki, RadsWiki, licensed under CC by SA 3.0. Further notes, original source page no longer online but can be found under https://web.archive.org/web/2010616344/http/radswiki.net/main/index.php. Title equals file necrotizing_enterocolitis_202.jpg. Overlay. Pneumatosis intestinalis and free air in necrotizing enterocolitis VV. X-ray abdomen, cross-table lateral view, of an infant with necrotizing enterocolitis. Small collections of gas, pneumatosis intestinalis, examples indicated by arrowheads, are visible within the intestinal wall. Free intraperitoneal air has ascended to a non-dependent position within the anterior abdomen and has extended into the anterior abdominal wall, green overlay. Red line, nasogastric tube. Source, copyright IMPP. Uronecrotizing enterocolitis, 2/3. Overlay. Pneumatosis intestinalis and free air in necrotizing enterocolitis VV. X-ray abdomen, cross-table lateral view, of an infant with necrotizing enterocolitis. Small collections of gas, pneumatosis intestinalis, examples indicated by arrowheads, are visible within the intestinal wall. Free intraperitoneal air has ascended to a non-dependent position within the anterior abdomen and has extended into the anterior abdominal wall, green overlay. Red line, nasogastric tube source, copyright IMPP. Uronecrotizing enterocolitis, 3/3. Overlay. Necrotizing enterocolitis. X-ray abdomen, AP view, of a premature neonate. Multiple loops of gas-filled bowel are seen, some of which are accompanied by linear, example indicated by red arrowhead, and bubbly, examples indicated by green arrowheads, lucencies that indicate intramural gas, pneumatosis intestinalis, areas in green circles. Subtle linear lucencies, examples indicated by black arrowheads, projecting over the right upper quadrant might indicate portal venous gas. There is no pneumoperitoneum. An NG tube, yellow overlay, terminates in the stomach. Source, pneumatosis intestinalis und hepatis bei NECL, CRAP, 001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 4.0. Uronecrotizing enterocolitis, 3/3. Copyright. Overlay. Necrotizing enterocolitis. X-ray abdomen, AP view, of a premature neonate. Multiple loops of gas-filled bowel are seen, some of which are accompanied by linear, example indicated by red arrowhead, and bubbly, examples indicated by green arrowheads, lucencies that indicate intramural gas, pneumatosis intestinalis, areas in green circles. Subtle linear lucencies, examples indicated by black arrowheads, projecting over the right upper quadrant might indicate portal venous gas. There is no pneumoperitoneum. An NG tube, yellow overlay, terminates in the stomach. Source, pneumatosis intestinalis und hepatis bei NECL, CRAP, 001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 4.0. Uronecrotizing enterocolitis, 1/1. Bilious vomiting in an infant, i.e., possible intestinal obstruction. /SJ. Y, *NPO, ENG or OG tube placement E4 fluids /E correct electrolyte abnormalities. Hemodynamically unstable or signs yes of peritonitis, example fever, guarding, and rebound tenderness. SEI no. Yen. Abdominal X-ray. XJYYYY. A monumoperitoneum dilated loops double bubble SE. A usage enema pneumatosis, portal, example Riegler sign, of bowel sign panus ICETDS, venous gas I. Absence of stool filled colon in RLQ /Y. YYSE. Contrast enema upper GI contrast study. XSJ1 abnormal duodenojejunal junction location. Rectosigmoid obstructed duodenum with microcolon transition zone corkscrew appearance VVVV, 4, E, S2, 2. Equals rarer Hirschsprung equals match rotation with necrotizing bowel perforation meconium ileus miscea duodenal atresia midgut volvulus enterocaldal. XYYXX underscore. Y% and YJ. YVYVV, at. 4 antibiotics plus refer to meconium, beetle refer to duodenal refer to volvulus and intestinal refer to necrotizing, equals Hirschsprung A, XAE, emergency surgery ileus article disease article atresia article malrotation article enterocolitis article NEJXYX% YYXXYXY. Management of bilious vomiting in the newborn 4. Copyright Boss. XX vitamin K deficiency bleeding of the newborn. Vitamin K deficiency bleeding of the newborn, VKDB, refers to spontaneous bleeding in a newborn caused by a deficiency of vitamin K-dependent coagulation factors. As vitamin K does not cross the placental barrier, is not present in breast milk, and is not synthesized in the sterile gut of a newborn. Vitamin K levels are low in all neonates. VKDB is rare in industrialized countries because most children receive a vitamin K injection at birth. VKDB is categorized as early onset, within 24 hours after birth, classic, within 4 weeks, or late onset, between 2 to 8 months. Bleeding is usually intracranial, subgaleal, gastrointestinal, or nasal. Treatment is focused on managing the bleeding with, example transfusions and restoring bleeding homeostasis by administering vitamin K. OE. Epidemiology. Without prophylaxis, affects 0.25 to 1.7% of newborns. Epidemiological data refers to the U.S., unless otherwise specified. WI. Add 2 shared notes. Manage. Etiology. The underlying cause is always a deficiency of vitamin K, which can be due to various factors: exclusive breastfeeding, low vitamin K levels in breast milk, most important in late-onset VKDB, low liver storage capacity, poor placental passage of vitamin K deficiency in the mother, example because of anticonvulsant therapy, most important in early-onset VKDB, maternal malnutrition, underdeveloped intestinal flora, which produces vitamin K, example due to premature birth. Chronic diarrhea of the newborn plus long-term antibiotic treatment in newborn cholestatic diseases, example biliary atresia, references to VAEE Sac-Nate Papas. Classification. Early onset, within 24 hours after birth, intracranial bleeding common. Classic, within 1 week after birth, intracranial bleeding rare. Late onset, between 2 to 8 months after birth, intracranial bleeding common. OOE. Clinical features. Easy bruising. 1 bleeding and signs of blood loss, example pale skin, hematuria, hematochezia. QS. Diagnostics. Coagulation studies, *1 prothrombin time, PT, normal or T-activated partial thromboplastin time, PTT, normal bleeding time * factors IL, 6, 9, and X. Back collapse. Fine text outline. Vitamin K deficiency bleeding of the newborn. Etiology. The underlying cause is always a deficiency of vitamin K, which can be due to various factors: exclusive breastfeeding, low vitamin K levels in breast milk, most important in late-onset VKDB, low liver storage capacity, poor placental passage of vitamin K deficiency in the mother, example because of anticonvulsant therapy, most important in early-onset VKDB, maternal malnutrition, underdeveloped intestinal flora, which produces vitamin K, example due to premature birth. Chronic diarrhea of the newborn. Long-term antibiotic treatment in newborn cholestatic diseases, example biliary atresia, references to W.A. Ashar. Classification. Early onset, within 24 hours after birth, intracranial bleeding common. Classic, within 1 week after birth, intracranial bleeding rare. Late onset, between 2 to 8 months after birth, intracranial bleeding common. Augury. Clinical features. Easy bruising * bleeding, and signs of blood loss, example pale skin, hematuria, hematochezia. 6GS. Diagnostics. Coagulation studies, *1 prothrombin time, PT, normal or T-activated partial thromboplastin time, PTT, normal bleeding time factors IL, 7, 9, and XJ. LOE. Treatment. Transfusions as necessary. Administration of vitamin K. WAYOA5ST. Prevention. In the U.S., all newborns receive intramuscular vitamin K, 0.5 to 1 milligrams, at birth. X. Chorioamnionitis, neonatal infection, and omphalitis. Chorioamnionitis is defined as an intrauterine infection of the fetal membranes and amniotic fluid caused by bacteria ascending from the vagina. The most common pathogens are ureaplasma and mycoplasma species. Infected women typically present with fever, purulent vaginal discharge, and malodorous amniotic fluid. The combination of maternal, 120/min, and fetal tachycardia, 160/min, is highly indicative of intrauterine infection, and the condition should be managed promptly with antibiotics, supportive care, and possibly early delivery. Chorioamnionitis, as well as colonization of the maternal genital tract with group B streptococcus, may also be the cause of dangerous infections in the newborn. These include pneumonia, meningitis, and sepsis, and may be difficult to differentiate because symptoms in neonates are often nonspecific. Common findings include irritability, lethargy, temperature changes, dyspnea, and signs of cardiocirculatory distress, example hypotension. If neonatal infection is suspected, diagnostic procedures should be initiated immediately to identify the pathogen and source of infection, example blood and urine cultures. Management consists mainly of swift initiation of broad-spectrum empiric antibiotic therapy. Without proper treatment, systemic neonatal infections are associated with a high risk of complications and increased mortality rates. Newborns are also commonly affected by localized infections such as omphalitis, an infection of the umbilical stump. The condition is most often caused by Staphylococcus aureus and group A streptococcus and occurs 3 to 9 days after delivery. Clinical features include localized inflammation, swelling, and purulent discharge, which may progress to complications like sepsis and necrotizing fasciitis if not treated adequately with antibiotics, example ampicillin, gentamicin. CE. Chorioamnionitis. Etiology. Scent infection of the amniotic fluid, fetal membranes, and placenta. Scent most commonly due to ascending cervicovaginal bacteria. One common bacteria, Ureaplasma ureolyticum, up to 50% of cases, Mycoplasma hominis, up to 30% of cases, Gardnerella vaginalis, Bacteroides, Group B Streptococcus, E. coli. Scent risk factors: prolonged labor or premature rupture of membranes, PROM, copyright pathological bacterial colonization of vaginal tract, example STDs, frequent UTIs, copyright latrogenic, multiple digital. Vaginal exams, invasive procedures, example amniocentesis, clinical features. Scent maternal O fever, 38 degrees Celsius or 100 degrees Fahrenheit, copyright tachycardia 120/min. O uterine tenderness, pelvic pain. E malodorous and purulent amniotic fluid, vaginal discharge. O premature contractions, PROM. E fetal tachycardia 160/min. In cardiotocography diagnosis. Chorioamnionitis is a clinical diagnosis, fever plus equals one additional symptom. Tests support or confirm diagnosis if the clinical presentation is ambiguous, example in subclinical chorioamnionitis. Scent maternal blood tests. O leukocytosis 15,000 cells/PL, 70 to 90% of cases, OTCRP. Scent bacterial cultures. O urogenital secretions, copyright amniotic fluid, most reliable, but rarely conducted, scent group B streptococcus screening, cervicovaginal and rectal swabs management. Scent maternal antibiotic therapy. O vaginal delivery, 4 ampicillin plus gentamicin, broad coverage, 1 O cesarean delivery, 4 ampicillin and gentamicin, plus clindamycin, anaerobe coverage to minimize post-cesarean complications, example endometritis. Scent delivery. O swift delivery is generally indicated to minimize both maternal and fetal complications. O cesarean delivery is not generally indicated, but is often necessary because of obstetrical complications, example insufficient contractions. Scent for treatment of newborns, see neonatal infection below. Complications: maternal o uterine atony, postpartum hemorrhage, endometritis, copyright septic shock, DIC, venous thrombosis, pulmonary embolism, death, sent fetal/neonatal o fetal death, premature birth. Back collapse, find text outline. Sent fetal/neonatal, copyright fetal death, premature birth, asphyxia, intraventricular hemorrhage, cerebral palsy o neonatal infection, see below. References, 2-11 I3 I41. WA. OXO neonatal infection. Etiology. Sent early onset infection/sepsis, copyright. And Streptococcus agalactiae and Escherichia coli are the most common causes of both early and late onset neonatal sepsis. Symptoms. General presentation. Nonspecific, scent irritability, lethargy, poor feeding, temperature changes, fever and hypothermia both possible, scent cardiocirculatory, tachycardia, hypotension, poor perfusion, and delayed capillary refill. 3 SEC1 respiratory, tachypnea, dyspnea, example expiratory grunting, apnea, more common in preterm infants, scent skin tone, jaundiced and/or bluish gray, indicates poor perfusion. Specific symptoms. Scent neonatal meningitis, copyright often no signs of meningism. 4O early phase, general symptoms, see above, vomiting o late phase, bulging fontanelles, shrill crying, seizures, stupor. Scent neonatal pneumonia, copyright tachypnea with intercostal/sternal retractions and nasal flaring, reduced oxygen saturation with cyanosis. Diagnosis. Scent blood cultures or urine culture for suspected UTI, copyright in GBS sepsis, blood agar plate reveals B hemolytic, gram-positive cocci that enlarge the area of hemolysis formed by S. aureus, scent blood tests o leukocytopenia or leukocytosis, thrombocytopenia OTCRP, lumbar puncture, tests cerebrospinal fluid for possible meningitis, scent chest X-ray, may reveal clear signs of pneumonia, example segmental infiltrates, but more often nonspecific with diffuse opacities management. Supportive care, cardiopulmonary monitoring and support, broad-spectrum antibiotics, LV ampicillin and gentamicin. Back collapse, find text outline. X chorioamnionitis, neonatal infection, and omphalitis. Diagnosis. Scent blood cultures or urine culture for suspected UTIO in GBS sepsis, blood agar plate reveals B hemolytic, gram-positive cocci that enlarge the area of hemolysis formed by S. aureus. Scent blood tests o leukocytopenia or leukocytosis, thrombocytopenia OTCRP. Scent lumbar puncture, tests cerebrospinal fluid for possible meningitis. 1 Scent chest X-ray, may reveal clear signs of pneumonia, example segmental infiltrates, but more often nonspecific with diffuse opacities management. Supportive care, cardiopulmonary monitoring and support, scent broad-spectrum antibiotics, 4-ampicillin and gentamicin. Copyright indications, clinical suspicion, confirmed or suspected maternal infection, example chorioamnionitis, adapt therapy according to antibiogram results. Prevention. Prophylaxis for neonatal GBS infection, see prenatal care, prognosis. May cause septic shock within hours if treatment is inadequate, mortality rate up to 50%, scent. The longer symptoms are present, the higher the risk of developing meningitis. References 6 Lee 7 Islzeel Old 11112. OICES. Omphalitis. Etiology. Scent bacterial infection of the umbilical stump occurring 3 to 9 days after delivery. Scent pathogens, Staphylococcus aureus, Group A Streptococcus, E. coli, Klebsiella pneumoniae. Copyright Clostridium tetani, common cause of omphalitis and neonatal tetanus in developing countries. 1 Scent risk factors, low birth weight, prolonged labor, maternal infection. Symptoms. Scent periumbilical redness, tenderness, swelling, and hardening purulent discharge. Signs of systemic infection, see neonatal infection above, diagnosis. Scent. Generally a clinical diagnosis, although cultures should be conducted. Scent. Bacterial cultures, pathogen identification and antibiogram, sample of discharge. In systemic infection, blood and cerebrospinal fluid cultures, detection of sepsis and meningitis, management. Scent. Broad spectrum for antibiotics, anti-staphylococcal penicillin, example oxacillin, plus aminoglycoside, example gentamicin. Scent. Surgery, complete debridement if complications arise. Complications. Sepsis. I. Scent. Necrotizing fasciitis and myonecrosis, infectious muscle involvement rare, associated with high mortality rates. Prevention. Keep the navel dry, frequent diaper change. Scent. Observe general hygiene measures. 4. 5 references. 13 IL1. Back collapse. Find text outline. Urochorioamnionitis, neonatal infection, and omphalitis, 1/1. Omphalitis in a newborn. Ventral view on the umbilical region of a newborn, 5 days old. The umbilicus and surrounding tissue appear erythematous. The umbilicus is edematous and still connected to a necrotic, reddish-black umbilical stump. These features likely indicate omphalitis, which may progress to sepsis.